Good morning, everyone, and welcome to the day 2 of live operated ear reconstruction workshop. I hope you are ready for another day of learning and hands-on practice, which is coming up tomorrow morning. Yesterday we
Hello.
covered the basics, and today we'll focus more on the advanced
Hello.
techniques. Our expert will guide you through key
Hello.
procedures. So please feel free to ask questions and engage with each other. Let's make today another productive and insightful session. Thank you for being here. And we'll begin the
Hello.
morning with Dr. Parag Delang sir's talk on Furman technique. Sir, I welcome you.
Hello. This is Pratik. Hello.
Morning everyone. You're all well fed and done. Okay. So this is a brief overview about the Furman technique. I'm sure some of you must have read about it, and those of you who have not read about it, probably they should encourage you to read about this particular technique. Now, as we all train, we more or less are always taught the Nagata technique, and it's a beautiful technique, there is no doubt about it. But the Furman technique is a different approach to ear reconstruction. And when you learn the skin approach and also the elevations, you can apply it not only to microtia but also to post-traumatic cases, other issues of the ear. So this is a brief overview of my experience with the Furman technique. Now, as we all know, ear reconstruction is not easy. It is like climbing a cliff, and you are not sure till the peak where you are going to land. So, what makes ear reconstruction so difficult is that it's a very unique organ. I don't think we have any other organ which is a wafer thin cartilage in between, and there are two skin surfaces on either side. And plus, the skin envelope is so thin, the cartilage is so thin that everything is very unforgiving. Plus, if you throw in the third dimension, that's when it starts becoming really scary. How do you create the depth of the concha? How do you create the elevations? And that is something which you need to train. Unless you train, you won't be able to replicate the intricacies of a normal ear. Everyone can make a ear. The difficult part is to make it look like a natural ear. I feel when you reconstruct ear for a patient, the end point should be that it should not draw any attention to that ear. If the patient is able to trim the hair and keep short hair, that is a hallmark of a successful ear reconstruction. So the challenges in ear reconstruction are multiple. You need to deal with whatever is available in the local area. The local skin may not always be very nice in terms of the color or in terms of the scarring. If there have been any previous attempts, then your ear reconstruction can get into a lot of trouble. Plus, age of the patient is something you can't really control. Cartilage calcification is not something you can control. So again, age is not something which is an absolute number. I have seen several patients who were in their 40s and they get absolutely nice and pliable cartilages. And sometimes you get patients who are in their 20s and they have completely calcified cartilages. So that's something which is unpredictable and you can't control it. If there is any ear canal, then always there is a chance of active infection in the local area, so you need to deal with it before you start your reconstruction. And then, of course, managing patient expectations is what causes graying of hair. Historically, I'm very happy always when I see this slide that India has been at the forefront of ear reconstruction, and in the Sushruta Samhita you can see a lot of references to the pedicle cheek flap. This has got to do with the fact that in ancient India probably chopping off the ear and nose was a very common form of punishment. In European literature, if you look at it, Tagliapozzi was the one who first reported use of post-auricular tissue flaps for ear reconstruction. Of course, Guinness was the one who started doing what we still do today, which is to take out costal cartilage. Now he used not only autologous, he also used allografts and xenografts. The results now, if you look at them, are not very great, they were primitive, but that was the beginning of ear reconstruction. Dancer, of course, described the 6-stage auricular reconstruction, and form of a definitive surgery in plastic surgery. Brent brought it a lot of limelight, and his series of 606 cases using contralateral costal cartilage is what was considered the epitome of or the pinnacle of ear reconstruction. However, I believe ear reconstruction was elevated to an actual art by Dr. Nagata. The Nagata approach completely changed the way ear reconstruction was performed. And of course, Dr. Fermin has worked upon Dr. Nagata's concept, and she has developed her own skin approach and the projection concept. I think Dr. Satoru Nagata was an original thinker. He was a true genius. He was the first who created a three-dimensional ear framework. Till then, if you see Brent's ears, they were all kind of flat. They didn't have that kind of a projection. He was the one who pioneered the use of stainless steel wires for a stable framework, and I feel that is his greatest contribution to plastic surgery. He also described the split lobule technique for creating a natural looking lobule. He described the use of banked costal cartilage for improving projection in the second stage, and he also reduced the number of stages from 4 to 2. Dr. Fermin then described her skin approach. She focused on defining the tragus antitragus. If you just see the tragus antitragus, I feel her tragus antitragus is a little better than the way Dr. Nagata does it. She then also described the projection concept, which helps us give a better three-dimensional effect to the framework and improve stability of the framework. Now I'm not going to delve into Tanzer's classification. I am sure all of you know what Tanzer's classification is in microscope. So let us start with the Fermin classification. Now, if you have a patient who has microtia, how do you approach this? It is by seeing what the remnant is. So what you need to do is you take measurements of the opposite ear, or you make a template of the opposite ear in terms of the size of the opposite ear. Because the skin approach is determined not by what you feel like doing. It is determined by the size of the opposite ear. So how you do this is you draw this line which I showed yesterday. This is the height of the opposite ear. This is the width of the opposite ear. Then you take a skin hook and you attach it to the widest part of the ear. If this point reaches to this line, then you can use a transfixion approach, which is what we did yesterday. It is called as a type 2 incision. If this lobule is very short, very tiny, then there are two ways of dealing with it. One, you can use a Z-plasty like Dr. Nagata's, where this Z is designed in a way where you maintain this particular subcutaneous pedicle along with its vascularity. Now when Dr. Fermin came back after visiting Dr. Nagata, she started using this Z-plasty, but she always says that it didn't really work in her hands, and that's why she gave up using this Z-plasty. So what are the two main approaches that you need to learn are, one is this type 2 incision. Now as I mentioned, how do you decide the level of transfixion or the point of transfixion is by taking a skin hook and holding the highest point, or rather the broadest point of the lobule. You will find that beyond a certain point, the skin is deficient. It is no longer going to reach this line that you are drawing. So the point where you are, the maximal cranial point where it reaches this blue line is somewhere the line of transfixion that you will have. So the portion below this will have both the surfaces, the anterior and the posterior, because it is free. And when you perform this transfixion, the area above this will have only one surface, the anterior surface, which you will elevate after 6 months. So this is a type 2 incision. Now sometimes you have patients who have like a cauliflower ear deformity, and if you feel that the skin is not bad, the skin is supple, and you can probably find a dissection plane between the skin and the cartilage framework which is deformed, then you can take an incision which is called as a 3A. So 3A is an incision which you can take in the inner margin of the helical rim. It's a very concealed incision. You open up the skin pocket on either side, remove the deformed cartilage, and introduce your new framework in the same cartilage, in the same skin pocket, thereby obviating the need for a then of course you have a type 3B. So 3B is basically a skin incision which is away from the area of the reconstruction. So there are two areas where you can use a 3B. One is if you have a lobule which is very small and it is not going to reach the marking what you have done, then you can't really transfix it behind because it is too small a remnant. In which case you take an incision here, that is also called as a type 3B. Or if you don't want to disturb anything in this area, you can take an incision cranially. You can create a wide undermining pocket here and insert your frenulum. Of course, it is not in cases who have a ear canal which is present, but if you have cases of anosia where there is no ear canal, you can do this kind of an approach which avoids any incision in the local area. Now, for the second stage again, she has described four types of elevations. These are again, they can be customized as per the projection of the opposite ear. So if you have a patient who has a very prominent ear, then you elevate it like how Dr. Nagata has described. You put a cartilage block on the posterior aspect of your framework and cover it with a STPL. This is the typical type A. Type B is for Brent. So type B is similar to what Dr. Brent has described using a skin graft. But as Dr. Mandari mentioned yesterday, the projection may not be adequate. You may have chances of the ear retracting back. So it is not very commonly recommended or commonly performed. The only indication probably is when you have a bilateral microtia where you are going to create the projection yourself and you can maybe do this. Type C is also a very interesting kind of approach where you use the local mastoid fascia flap like a turnover flap, like the page of a textbook, to cover the cartilage on the posterior aspect of the framework. But the main workhorse which I use very routinely is the type D. Now type D is basically a tunnel which is created on the posterior aspect of the framework. While you are creating this tunnel, you need to ensure that there is adequate soft tissue which remains intact to cover this cartilage block. If you take an incision which is very flush with the cartilage framework, you may not have adequate tissue left, and if you take an incision which is very close to the bone on the scalp side, then again you may have problems inserting a cartilage in this tunnel. So the way you elevate the framework is important, but if you know how to do it, then the tunnel saves you a lot of time. It saves the patient an additional incision for the superficial temporoparietal fascia, and it can give you very good projection. Now, the third part of our classification is the projection part. So what exactly is the projection concept? The projection concept is basically the projection at certain strategic areas of the framework. P1 being a small piece which is added to stabilize the root of the helical ring and the tragus, which is what we did yesterday. If after reconstructing the framework, you feel that the depth of the concha is being deficient, so how created a third layer, you can add another cartilage behind the anti-helix as a P2. And if you feel that the patient has a very deficient mastoid and the ear lobe is really very not projected, then you can add another piece behind the lobule which is called as a P2. This projection concept is something which helps you achieve better grade specific areas of your framework will have much better projection, and of course it will improve stability of your framework. The part will not move anymore. And if you look at it, it doesn't add much to the total operating time. Hardly takes 5 minutes or 7 minutes to add another piece of cartilage. So this is an example of a P1. So P1 is a piece which is basically between the root of the helix and the tragus. So this stabilizes the root of the helix and it also gives additional projection to the tragus. The whole idea behind giving more projection to the tragus is that it gives the appearance that there is a ear canal, even though you may not be able to see it. So this is how P1 looks. This is the P2. P2 is a small cartilage piece placed behind the Y of the anti-helix and it enhances the depth of the concha. Now if you remember, I explained yesterday that this is the highest point of our framework. So this has to purpose is to give more projection to the locule. And this is how in children who are syndromic, who have a very recluded kind of mastoid, a P3 can help you get better projection in this particular. Now when we look at the goals in our ear reconstruction surgery, we need to create a ear which looks normal. That should be the end point. It should be symmetric with the opposite side. It should have a three-dimensional shape. And all this we should be able to achieve with an acceptable complication rate. By acceptable complication rate, I mean it should be less than 1%. And of course, you should use any kind of material which is going to last for a long time. Now the gold standard still remains autologous reconstruction. There are a lot of artificial materials which are available, but if you look at it, the autologous reconstruction will give you a lot of flexibility. It is not like a preformed size which you have to insert. So it gives you much more flexibility in terms of designing the framework. Makes it easier to achieve symmetry. Measure the opposite side and then you create what you need to create. There is much less chance of an infection, and there is much less, even if there is a minor infection, you can deal with it. There is definitely no rejection that is going to happen. And the best part is, this can be inserted under post-auricular skin. So if you look at the color match, there is nothing which can give you this kind of a color match. When you get a patient of microshare, this is the first decide what is the type of microshare your patient has. Look for other associated diseases. You need to document if the patient is normal or not. Probably you need to see this kind of data or if it is asymmetric as well. You need to check what patient is getting. As per having an eye, you can there are tests which you can perform. Look for presence or absence of the alarm to a particular ear. This is a similar ear. You don't want any colleague to discuss options for hearing. And nowadays in adult patients, I normally do a 3D CT scan of the chest to look for two things. One, if the patient has been previously operated, where we get the cartilage from, and if the patient is an adult, we need to see where the chest is. Once you are done with the initial investigation, you need to decide the skin approach. So you see again what is the type of microshare. You see the presence of remnants that the patient has. Then you need to compare the size of the opposite ear with the size of the side which is microshare. Look for any previous incisions in this area which you can use. So this is the main decision making that then you need to do. You have to decide on what type of skin incision you are going to do, whether it's going to be a type 1, 3A or 3B. You have to then decide on the type of framework. So in terms of the framework, Dr. Bermin has described the type 1, 2 and 3. The type 1 is the complete framework which has the tragus and antitragus both. A type 2 framework is somewhere where you don't need to make a tragus, like in a post-traumatic case or a burns case where the tragus is preserved. Your framework only has the antitragus. And a type 3 framework is where both the tragus and antitragus are already present and you don't need to make them. Then you need to see whether you need to add any projection piece. Now if your skin envelope is very tight and you feel that there is not enough space in the pocket to add a third layer, you may need to not add a projection piece. So it's not something which you need to do, but it is something you should do if you get the chance. And then you need to apply suction grains at the proper location. So I normally add 2 suction grains as you saw yesterday, one in the concyle area and one in the post-auricular area. So when the patient comes back to you for the second stage, again you need to decide on the type of fascia that may be required, what kind of projection the opposite ear has, and then decide on the type of elevation that you are going to perform, A, B, C or D. But if you look at it, after doing so many ear reconstructions, I feel is it really about the cartilage? Because cartilage carving is something you can learn by practicing on it, or keep doing it all the time. So you know what the highest point is, what the lowest points are, and you can keep practicing this till you perfectly. But then it is not only about cartilage, it is also about coaptation of the skin. And this coaptation of the skin, because if you keep carving cartilages, the shape becomes more or less easier to predict. This is with the P2 projection, and you can see the depth of the concha, the highest point of the antigens. All of this you learn by keeping doing it all the time. But it's also about skin coaptation. By skin coaptation, microtia always remains a challenge. The skin approach always remains a challenge, and therefore learning this technique will help you plan your incision, so that when you see a patient like this, you can easily decide what is going to be your skin approach. The cartilage carving, of course, will become a routine for you, and then you can plan the reconstruction. If you see a patient like this, you know that this is a 3B, cartilage framework remains the same, the incision is here, and that's your 3B. If you have a patient who has a slightly larger lobule, you realize that this is a patient for a type 2. It's a more type 2, but this is the framework which remains the same, and the result is the type 2. So deciding the skin approach is a very important part of your approach to microtia. Another patient where the lobule is very small, he has a rudimentary canal which was not found to be functional. So such patients also need a very high projecting tragus. Unless you create this tragus, you can't create the impression of the ear canal. So this is also very important. Sometimes you will have patients who are secondary cases, like this particular patient who was already operated twice before. She also had a skin graft on the two cervical surface. So in this kind of cases, then you try to use whatever is the maximum usable skin on the anterior segment, and increase the color match with the rest of it you can cover with a double barrette lutetia, and this is the outcome after 3 months. So the different types of skin approaches will give you the ability to have then some kind of predictability in your results. So this is a type 2 incision which I already told you. This is also a type 2 incision. So even in elder, older kind of patients, the cartilage sometimes is yellow, there are cartilage, there are cartilage red which can calcify, and then carving can become a little tedious. Of course, with lot of effort, you can still create a framework, and you can still give a reasonably decent result, but then carving is something which has to be done. Another child who had very small rudimentary lobule, he was not holding it for the type 2. First stage, this is after the second stage. Within this kind of a projection, without use of a double barrette lutetia, that is possible. You need to be able to elevate it and create a touch-up on the posterior surface properly, so that the projection matches the projection of the appendicular. These are some case examples of patients of microtia that are operated using the Perlin technique. So the different components of the ear. Now sometimes when you have a child who is very young, you may not have adequate width of the casing, like Dr. Sir usually likes it. You need to add some components here. You need to maybe lengthen the frame because the rim may not be long enough to function some. So this is the fillets in your reconstruction. You need to join it in a way where it's not visible, it shouldn't show through the skin, because the skin is quite unforgiving. Cartilage is something you can't really control. But then when you are able to make a proper framework, then the healing should happen satisfactorily. You should not have any gap in the incision. Everything should contour properly. So it's a constant struggle. Then the elevation should be done in a way where in a girl child especially you need to have some space where you can do a piercing in the future to create a lobule, preferably without a little bit of cartilage. For 5 mm space and put a skin graft. So with the proper projection, then you can create a normal looking ear. I normally do the piercing along with the second stage. I put a small plastic cannula and put on tight there, and the patient can then start wearing the earring after 15 days. Another example of reconstruction using the Perlin technique. So this is how a tunnel looks if you see it from behind. So there is a small incision in the soft tissue here, and then you elevate the tissues off the framework so that you have soft tissue on this surface and soft tissue on the framework surface, and this will be your cartilage which is put inside this tunnel. You can then fix it with 2 or 3 Teflon or monoclip sutures, and then this is the kind of projection you will get on paper, and that's how we do a type B. So when you do a proper tunnel this at least for 3 to 6 months. Don't expect it definitely going to go clear. This is a journey, and this journey is going to take time. This counsel will take probably 3 to 6 months. But when you do it regularly, you can definitely have results which are reproducible. There are results which you can tell to your patient that okay, even in a post-traumatic case, even if the communication is clear, you can achieve clear communication, clear symmetrical word, and the patient feels completely easy and reassured. Even in an adult, if the party calcified cartilage, they can do that. But then there are sometimes challenges which always remain, like you have patients who are close at ear, very low ear canal, dilated, and there is some wear. So how you deal with it is by a little bit of clipping, you clip the ears to the correct perineal point, because this is something very we can't really violate this knowledge physically. And then you do it on the creation of the material in such a way that you make the ear canal seem that it is at a higher location, though you really can't change the location much. There are sometimes patients who have absolutely unbelievable kind of microchias. I myself am amazed at what kind of anomaly this is and how do you approach this. There is a small remnant here, there is a small doublet here, and there is some kind of deformity of this ear, like multiple bands here. I don't know what classification you can use for this kind of microchia. So challenges still remain. You have to find a way through these challenges, and at the end of the reconstruction you should be able to give a semblance of a normal year after all these struggles. But once you are able to do it very routinely, then of course it does give a lot of joy. It is a surgery which will give you the thrill of climbing a mountain top. Now whether you will be able to climb to the top or you will be stopping somewhere in between depends on the tenacity that you have. Thank you. Any questions? Yeah, sure. So the cartilaginous part of the bone is something you can elevate slightly. You can take a suggestion around the cartilaginous part of the canal. You can take a foot, 2 inches, 3 inches,
Rajesh Maji. So, this is a 6-year-old child with a history of electrical burn in June 2024. Now he has presented with a superior helix deformity of the right ear post burns and healed with secondary intention.
You can see this child, he has total loss of the left.
So this is a 6-year-old child with a history of electrical burn in June 2024. Now he has presented with a superior helix deformity of the right ear post burns and healed with secondary intention.
You can see this child, he has total loss of the left ear, and on the right side he has loss of the portion of the upper 1/3 of external auricle. And as you can see, this part of the anti-helix is here, the root of the helix is here, and this anti-helix is here. So in this child, what could be done is just excision of this deformed portion of the helix and freeing the ear by incision on top and folding this flap behind the ear. This root of the helix could be joined to this thing, and then he can have a good definition. So that's a relatively easier reconstruction, and he might get a good outcome with that. So that's what we are planning to do.
So the additional information here is this child also had scalp burns on the left temporoparietal region. So we had done one transposition flap transposed from the vertex towards the left side, hence the scarring. So sir will be demonstrating the same, how to approach through that scar and reconstruct that right ear. And also the child has the complete obliteration of the left sided ear, which will be addressed later on. Coming to the next case.
You can see the left side. Is it visible to you? Left
Yes,
side.
sir. Yes, sir, it's visible, sir.
And the other side on the right side. So she has been operated twice. On the right side, full reconstruction was done. Something went wrong. So it is not up to the mark on the right side. On the left side, they've taken cartilage only for the one side. This side, some flap has been done, but no cartilage has been put in on this side. But you can see the incision line over here, scarring. There's incision line over here also. Can you see this? Can you see the scar line over here? One scar line here. Can you
Yes, sir.
little zoom?
Yes, sir, we can see, sir.
I believe it is visible. The deformity of the other side. Yeah, it is fine. थोड़ा zoom कम कर दीजिए. Now, because both the ears are deformed, so you have to make a template of the same stature or the size of the patient from some other person. So I made a template of a normal person of the same height and weight and something like. So that is what we have. Can you see this?
Yes, sir. Visible.
So I'll show you. So with the help of plain X-ray template, if somebody can come, can you please come? बेटा एक मिनट जाओ, उधर आ जाओ. So if you take the plain X-ray film template like this, can you see this?
Yes, sir. Visible.
And then you trace out the ear like of, if it is normal ear other side, then you can trace it like this.
Okay.
So with the help of that, we have made this template. Can you see this?
Yes, sir.
Can you see this template?
Yes.
Better now?
Visible.
Can you see this?
Yes, sir.
So now this template, normally if you see, the upper limit of the ear is normally at the level of eyebrow. Most of the time it is at the level of eyebrow.
Okay.
And the direction of the ear is along the direction of the nose. Sometime it is around 20 degree vertical than the direction of the nose. But
Okay.
in this patient, you see the direction of the nose and the ear slightly vertical. Can you appreciate this? This is the direction of the nose
Yes, it's
and this is direction of the ear. Almost the same, slightly vertical. So we already know the direction of the ear. It is a bilateral case, so we don't have a reference point on the other side, but usually along the direction of the nose, and sometimes it is around 20 degree vertical the direction of the nose. If you make it like this is fine. So the template which we have made is the template here. Can you see this?
yes, sir.
This is just to hold it. This is lobule. So
Yes.
lobule is short in this patient, so we'll use this lobule. And this is the height of the, can you see this?
Yes.
Looks little bigger. This template looks little bigger. I will make it little shorter. So this is the direction of the ear.
Okay.
This is the side, the highest point, and lowest point obviously is the lobule.
Okay.
Is that right?
Yes.
So we will be using this skin partly. So we'll be giving incision like this and excising whole of the remnant cartilage.
Okay, sir.
Maybe portion of the skin can be used, otherwise most of the cartilage will be covered by the temporoparietal facial flap. I can feel the artery here.
Okay, sir.
So this is the artery. We give incision like here. Shape को ज़्यादा किया है. So as you go superiorly, you can make it little wide. So this is the incision
Okay,
which
sir.
we are planning to give.
Okay.
And I'll inject a lot of Adaline saline before we take up the patient for surgical intervention.
Thank you, sir.
So any question anybody wants to ask, they are going to anesthetize the patient. Then I will inject Adaline saline, xylocaine with adrenaline, and wait for 20 minutes. So in that 20 minutes, we can discuss it out, whatever you want to ask me about this patient.
Hello, sir. Hello, sir.
Priyanka. Another template was made. Can you see this?
Yes, sir. We can see.
Now this has already been sterilized. This is the, yeah. This has been sterilized with ETO. It was given yesterday. So this is already with us, right? It was made a day prior to the surgical intervention. Okay.
Sir, can I ask a question, sir?
Something. Yeah.
Hello.
Yeah. Please go ahead.
Sir, what is your usual approach? You harvest extraperichondrially or subperichondrially?
So please come again.
Sir, how you harvest the cartilage? Extraperichondrially or subperichondrially?
So I will be taking subperichondrial, means leaving behind both the perichondrium, anterior and posterior perichondrium intact. And once we have taken out the cartilage, we'll make the perichondrial pocket with the perichondrium which is left behind. And whatever cartilage is left behind, the small pieces, they will be, the perichondrial pocket would be packed with the whatever the cartilage left behind. They actually get solidified in due course of time, and there is no defect if you see it after a few months. So I want to save the perichondrium on both the sides. So the dissection is little difficult, but it helps you out in maintaining the stability or integrity of the chest wall. Any other question?
How about when you get the subcostal margin, some authors advise leaving a rim of cartilage at the subcostal margin. so that the integrity is preserved. What is your take on it?
You know, if you maintain the subcostal margin, you will be maintaining the shape of the chest wall,
Yeah.
but there will be a defect superior to that. I hope you're getting my point.
Yes, yes.
You're only maintaining the edge of the chest wall cage, but superior to that, from where you've taken out a full thickness cartilage, there will be a defect.
Okay.
So if you do subperitoneal dissection, you're in fact reconstructing the whole of the cartilage which you have taken out. You're putting the cartilage, small piece of cartilage which are left behind, and they actually get consolidated, solidify, and there is no defect later on in due course of time.
Okay.
So that is Nagata's technique. Initially, Nagata was also taking out the cartilage with the perichondrium, but now he has changed it. Unfortunately, Nagata is no more, but one of his papers shows he will do subperitoneal dissection, make the skin pocket or perichondral pocket, and put whatever cartilage left behind with the help of a funnel.
Okay.
So he will completely fill the pocket, and it actually gets solidified. I also used to tape with perichondrium both the sides few years back to maintain the integrity of synchondrosis, because 7 or 8 are fused with the help of perichondrium.
Yes.
So if you take with the perichondrium, you take an intact 7th and 8th cartilage which is used for the basal framework. But now I understand that if you take it without perichondrium, it really helps out the patient due course of time.
Okay. Thank you, sir.
Sir, when you take the cartilage separately, so how you make the base frame? Like yesterday, Mohit sir showed if you have deficit, you join or you make from a single cartilage, like 7th or something.
So voice is not very clear over here. You wanted to ask something about the incision?
No, sir. Sir, what I am telling, suppose the cartilage width is not sufficient for the base frame creation, how you manage those cases?
Can you please repeat the question? If the cartilage is not sufficient,
Yeah, if the width of the cartilage is not sufficient for doing the entire base framework, how you do that? Means you do from a synchondrotic portion, or you take the cartilage separately and
see,
join and...
if for the entire base, if the cartilage is not broad enough,
Yeah.
you have to add the pieces as Dr. Mohit has done yesterday.
Yeah.
You need to add pieces to make the basal framework strong. So if it is not broad, then you need to put in the pieces together to make the basal framework. Sometime the helical rim also you need to add something, because sometimes even the 8 costal cartilage which is used for the helical rim falls short, so you need to add that portion also sometime.
And sir, in this case, will you add for the tragal plate, projection some cartilage, or you just make the framework without tragal pro?
Yeah, can you keep the mic little away from your mouth so that the voice becomes clear, because it's not very clear over here. Maybe it is echoing over here. Can you please keep the mic little away and repeat the question? Can you please repeat the question?
Sir, in this case, are you going to do the tragal framework also? Means, are you going to add the tragal cartilage in this case, sir?
In this patient, can you see the patient again? No. I would, because there is no tragus over here, so we would like to reconstruct the tragus also.
Yes.
Tragus is not there. So we would like to add the tragus also over here. And I'll show you the incision. I prefer to give submammary incision, but if you are giving submammary incision, the cartilage is lying with a little away from here, so you have to give a big incision. Or you can give incision directly over the 6, 7, 8 costal cartilage. But here I believe female patients, I want to give incision in the submammary area so that the incision is not visible in due course of time. So it will be a big incision, but in the submammary area. जिससे वो बन गया आपका. It is there. 60 ml.
Hello, gas OT. Hello.
Hello everyone.
Yes, sir.
Am I
Yes,
audible?
sir. Yes, sir. You are audible, sir.
So let us zoom on to the ear marking. So we have a case who had a road traffic accident, and after road traffic accident he has got a deformity of his ear which is like a cauliflower ear. Now if the quality of the skin was good, we could have tried to do a type 3A incision, which I showed in my presentation, where the incision is here. We free up the skin and put the cartilage framework. But if you remember, as I explained to you, it all depends on the size of the opposite ear. So if you see the size of this ear, it is this much. Turn करिए, turn करिए, घूम जाइए. And if you look at his opposite ear, this is only this much. So the opposite ear is quite large. So when you have this much of disparity, you can't really do a type 3A incision. So what we are going to do is we are going to use a type 2 incision to transfix the lower part of his ear. Now he has a good antitragus and tragus which we don't need to reconstruct. So the type of framework that we will be making is called as a type 3 framework, and the type of incision is type 2. So in this particular case, I will be doing a Fermin type 2 incision and a Fermin type 3 framework. So let us first mark the opposite normal ear. Please turn. पूरा घूम जाए. So I will first create a tracing of the normal ear. Now as I mentioned yesterday, I like to keep this drawing like a millimeter short of the actual size to account for the skin thickness. And once you draw the tracing of the normal ear, then you take two measurements. One is from the lateral canthus to the root of the helix. So let us take that. This is around 7.5, and then from corner of mouth to the base of the ear lobe, which is 9.5. So आप पहले मेरी तरफ ऐसे बैठे straight. So you first look at the patient from the front and you mark the uppermost point of the ear. So as I said, this point is inviolable, you can't really change this point. So once you have marked that point, then you see the measurements from corner of mouth to the base of the lobule, which is uninjured, so it is normal. So the only marking we'll need for the upper part, so corner of eye to base of the ear, which is somewhere there. So then you place the tracing that you did on the side to be reconstructed, and you realize that what we need to make is the part above this horizontal line. So the portion below the horizontal line he already has. What he doesn't have is the part above this line. So the highest point of his reconstructed ear will reach this. So I am drawing the tracing of what we want to reconstruct. Is this visible?
Yes, sir.
And
it's visible,
you
sir.
extend this line lower down, and then you will arrive at a place which will be the transfixion point. So roughly this is going to be the point of his transfixion. So if you look at it from the back of his ear, this will be the transfixion line. So the ear will be transfixed at this place. The lower part will have both the surfaces preserved and the upper part will have only one surface. We will probably get rid of the damaged and scarred skin, and then we'll have the place to insert our new framework. Because this skin is really badly damaged, I don't think we can salvage much of it. So I will see on table how to excise this skin. Then you draw two horizontal lines, one from corner of the eye, one from corner of the mouth. Then you draw the perpendicular line. Now the axis of the ear is roughly parallel to the axis of the nose, or you can say it is a line which is at 20 degrees to this perpendicular line. So this angle is 20 degrees. So this is going to be the axis of our new ear. So I'll show it again. First I drew a perpendicular, then I checked the axis of his nose, and roughly parallel to the axis of the nose with a slight inclination. So around 20 degrees is what is the axis of the ear. So this is going to be the plan. We will harvest cartilage from the same side like how we did yesterday. Create a pocket for the placement of the cartilage in the lobule, and of course reconstruct the missing part of the ear. I also like to draw the location of the drain before surgery. So this is the plan. So we'll come back to you in some time once we are ready. Any questions?
Hello. Sir, we have a question, sir. Parag, sir.
Yes. Yes, please.
Sir, we have a question on the chat box, sir. How to identify the transfixation point?
How to
Sir, am I audible? Sir, you're not audible, sir. Hello. Sir, are we audible, sir? Sir, we can't hear, sir.
Am I audible now?
Yes, sir, you're audible, sir.
Yeah, so what we do is we make a tracing of the opposite ear, and on the basis of the size of the opposite ear, we draw this marking. Now,
Hello, sir. Sir, you're not audible, sir. Hello. Hello.
I think the voice broke off in between.
Yes, sir. So we can hear you now, sir.
So could you understand the transfixion point, or should I repeat?
Please repeat, sir.
I'll repeat.
Yes, sir.
Okay. So you take the measurements or tracings of the opposite ear, and you draw this on the side that you want to operate on. After you do that, you catch hold of the normal part of the ear. So if I, for example, hold his lower ear and bring it to the blue line, it is reaching easily. If I go slightly higher up, it is still reaching, and then this is the highest point which is reaching this blue line. If I go above this line, the skin is deficient. It is not going to reach the blue line. So the highest point on the lobule which is able to reach the blue line is the line of transfixion, is the point of transfixion. So above this we will create a pocket for the new framework. Any other questions?
Yes, sir. 1 minute, sir.
Good morning, sir.
Good
Sir,
morning.
I wanted to know how to decide if we want to take ipsilateral or contralateral costal cartilage. Like, what are the factors? How do we decide that? Or
Can you talk a little louder? I am unable to understand.
sir, I wanted to know how do we decide if we take ipsilateral or contralateral costal cartilage?
So in the Fermin technique, it is always the ipsilateral cartilage. Only if the patient has had a surgery before and the ipsilateral cartilage is not available, then we use the contralateral.
Yes,
Otherwise,
sir.
it is always ipsilateral.
Another question. Can we also do this in one stage using the temporoparietal fascia flap?
Yes, you can, but temporoparietal fascia does give an inferior color match, and it is not really going to give a proper color match. So it's better to do it in two stages because it will give him a very good color match. But of course, you can do it with a temporoparietal fascia in a single stage if you want. I feel that temporoparietal fascia sometimes tends to be a little unpredictable. The vascularity of the flap is something you can't control, and you should offer solutions to the patient where they normally shouldn't need a revisional surgery, because then a revisional surgery becomes a problem.
Thank you, sir. OT1, are we audible?
So we'll start the anesthesia and we'll come back to you soon.
Yes, sir. So there is a question by Chaudhary sir to Bhandari sir. OT1, are we audible? Sir, we'll get back to you with the question, sir.
On. Hello.
Hello.
Are you with us? Can you hear me?
Yeah. Yes, sir. We can hear you.
So I'm injecting the Adaline saline, Xalocan with Adaline solution. So starting from the top, just to have a feel that you are in the plane where you want to dissect. And what you can see here, can you see the bevel of the needle?
Yes, sir.
Bevel of the needle is facing towards the skin. I'll show you. If you do it other way around, तो syringe टूट गया आपका. मेरे को single use वाला नहीं चाहिए. I don't want single use. I want to use it again and again. इसको पकड़ के फेंक देंगे. हाँ. Oh, I don't want single use. तो कई बार I want to use 2 ml syringe because you have better control with the 2 ml syringe. Because you want to inject very little. With 10 ml, it becomes very difficult to control it. So I believe they have only one-time use. Difficult to get 2 ml syringe which can be used again and again. Okay. So I'm waiting for the syringe to be changed. So this is what I was telling. This is facing up. I'll show you if you do it other way around what happens. See, if you do it other way around, it is difficult to inject. So this is facing upstairs. Can you see this? It
Yes,
easily
sir.
swells up. So I will inject a lot of it, maybe around 40 to 45 ml. I'm sorry, very sorry. इसका कनेक्शन ठीक नहीं है ना. कोई बात नहीं, अभी पकड़ के करता हूँ उसको. पकड़ के करता हूँ. So that is what I was saying.
Sir, are you using diluted adrenaline, Xalocan with adrenaline?
This was, सिस्टर बता सकते हैं कैसे बनाया आपने?
Not audible, sir.
So as most of the people make, you add 1 ampule of Adaline
Sir.
into 200 ml of saline. So that makes 1 in 200,000 dilution. That everybody uses that 1 in 200,000 dilution.
Okay, sir.
So I've taken out 45 ml of this solution and 15 ml of Xalocan with adrenaline. That makes it 60 ml of 0.5% Xalocan
Yes, sir.
with adrenaline, which is 1 in 200,000 dilution.
Okay.
And when you add 1 ampule of adrenaline into 200 ml of saline, 1 ml will contain 5 mics in 1 ml, and dose of adrenaline during anesthesia is 5 mics per kg body weight.
Yes.
So because 1 ml contains 5 mics, so whatever the weight of the patient, that much can be given. I hope you understand.
Yes, sir.
Because 1 ml contains 5 mics, and the dose is 5 mics per kg body weight. So it will be 1 ml per kg body weight.
Yes.
So if the weight of the patient is 50, the limit would be 50.
Yes.
If the weight is, that is so far the Adaline is concerned. Xalocan is 5 to 7 milligram per kg body weight. So we are way below the mark.
Okay, sir. Are you adding, sir, bupivacaine for long-term anesthesia to remain for this post-operative
बड़ा needle ठीक
analgesia?
नहीं है. कुछ पूछ रहे, मेरे को समझ में नहीं आ रहा है. I'm not able to.
Sir, are you using bupivacaine adding this solution?
We are using Xalocan with the Adaline, not bupivacaine. The syringe is not good. It is slipping all the time. I believe they have better syringes with one-time use, but I'm not using that.
Yesterday, sir, Dr. Chaudhary asked one question regarding spinal needle can be used for this patient, sir. If you use spinal needle repeated injection, multiple injection will be not be
So
required.
I want to give repeated injection deliberately. That's what I've told yesterday also.
Okay.
I make a bleb. See, I have made the bleb and then I'm going through that bleb so that I'm not hitting because it's only elevated. So I'm not hitting the veins or the arteries underneath because this portion is only elevated. So most likely I'm not hitting it. So
Thank you.
deliberately I take only 2 ml syringe. I will not be taking the spinal needle. Otherwise we have 26 or 25 long needles also. So I deliberately have taken this and 2 ml I take because I believe it is a better control with the 2 ml. Because this much push will have 0.5 ml. In 10 ml this much push will have 2 ml or 3 ml. So 2 ml will have a better control. And then when the surface area is less, the amount of force you apply, the pressure you give, the amount of force is more because the surface area is less.
Yes, sir.
This is the area of artery vein would be nearby, so one has to be very careful over here. Every time you inject, you want to go through that area which has been already elevated and aspirate and inject. And my anesthetist will always ask me, she would be standing nearby, कि sir aspirate करते रहिए.
Have you ever faced xylocan toxicity in this microcephaly patient?
Yeah.
Xylocan toxicity?
No, I have never come across toxicity of, because I am always short of toxic dose. But you can probably have reaction with the preservative it contains. Xylocan sensitivity is very rare, but sometimes with the preservative you can have this reaction. I never came across with any reaction or untoward effects of the xylocan with adaline.
So what is your preference, sir? This paraben is the preservative, and this paraben is mostly responsible for the xylocan toxicity.
यार मेरे को बोलते जाओ, मेरे को सुनाई नहीं पड़ रहा ठीक. क्या कह रहे हैं?
Paraben.
You're absolutely right, because the preservative it contains probably is responsible. So if you have to give only plain, it is better to give Xylocard because it does not contain any preservative. But if you want to add adrenaline, or maybe you can add adrenaline little more in the case of if you want to give Xylocard, that is without preservative. कोई अनस्टाइल वो है अपने पास में स्केल?
Sir, there is a question in the chat box, sir.
Sorry?
Sir, there is a question in the chat box by
Yeah.
Arun Kumar Chaudhary, sir. Sir, he's asking about the choice of site for cartilage harvesting and its logic, sir.
Sorry.
Choice of site for harvest of cartilage and logic behind it.
So I'll just show you. Let me inject. I hope you were there when Dr. Mohit was carving out. You were there when Dr. Mohit was doing the carving?
Sir, this question has come on the chat box, sir, by Arun Kumar Chaudhary.
No. No, that is there. I just wanted to tell you the things. I'll just give you the answer. This skin will be elevated and the cartilage, whatever is left behind, will be taken off. It will be thrown away. It cannot be used. इसको थोड़ा हाथ से क्लीन करना पड़ेगा. There is a dirt inside, no? I want to raise it so it becomes easier to elevate the skin from hydrodissection. Of course. So I always used to keep micro instruments like forceps, a needle holder and Caesar. If inadvertently injure the vein, I'll take 9 and make one suture. Because it's difficult to cauterize because there's a rent in the vein. So this can happen anytime. If you're not careful, or sometimes the veins are very, very superficial. Like they are very going just attached to the skin, then it becomes very difficult to save it. So this can happen. Now DB fascia is very short. It will never work. Then you have to look for the vein posteriorly. This can always happen vein ka. See, can you see this?
Yes, sir.
Now 10 centimeter is very far off. Up to 7 centimeter is the fascia, which will be viable.
Yes.
Can you see the change in the plane? Now it changes like this.
Yes.
It is changing. So the area from where it changes, beyond that, from this junction, it becomes very random pattern. So almost 7 centimeter would be fine. If you go little beyond that, and if we turn it 7 centimeter, 8 centimeters only required because it's a smaller ear.
Yes.
And see over here, this will be around 8 centimeter. The amount of solution we have given in the area. So it will be around 8 or 10 to 8 centimeter around.
8 into 8.
And this is the area of nerve. So we don't go up to here, right?
Okay.
So what the question you asked me, sister, this. So supposing if you take the cartilage from the opposite side, see? Can you see this?
Yes, sir.
This will be the superior margin.
Yes.
Superior margin, inferior margin. I hope you understand. Pen dikhana mujhe, pen. So it will be curved like this. Rib would be curved like this.
Okay.
The 8th rib which will be used, 6, 7 is for the basal cartilage. 8th is for the helical margin. So this is the superior margin. On the right side it will be like this.
Okay.
And this portion which is close to the stomach is thicker. As you go lateral, it thins out. This portion should form the root of the helix like this. And it is curved like this. If you take it on the right side for this patient, it is curved like this. And that is the curvature you want. So if you take it from the opposite side, you get the same curvature which you actually want. Because you want this portion to form the superior margin because it's smooth. The inferior margin is not smooth.
Yes.
So that is the reason I believe the contralateral would be better. Otherwise you can shave off this side and you can turn like this also. But then it makes it very thin. So it is better to take it from the opposite side because of this reason. Yesterday is taken from the same side, so it's finding it difficult to curve it like that. So that I believe should be the contralateral side. But we'll be discussing in the afternoon that the Brent takes from the contralateral side, the Nagata and the Firmin they take it from the ipsilateral side. Right? So here I believe, in this patient we have to take it from the same side because the right side has already been taken. Right? But you can't help it. You have to take it from the same side.
Yes, sir.
Or you can flip it, then you can smoothen out the inferior margin, because otherwise the superior margin is very smooth, rounded contour which actually gives the thing. But let's see. So now I will come after 15 minutes to raise it. Then you can ये हटा लीजिए सब, है ना?
Sir, one
इसको
question
ना
regarding.
ऐसे ऐसे
You
करके
have
लगा
added,
देना.
sir, Xylocan for post-operative analgesia, but the surgery will continue for around 3 to 4 hours.
अच्छा,
And will it be helpful during this period? The
चलो
post-operative
लगा
is
लो.
this.
बस थोड़ा पेशेंट को ऊपर लाएंगे. पूरा शीट खींच के पूरा शीट. एनेस्थेटिस्ट को नहीं पूछा? ओके. ठीक. That's it. And we're sitting here. हाँ जी, हाँ हाँ. एक इधर ना जेली या ऑइंटमेंट लगा दो. ठीक है? Okay, I'll come after 15 minutes.
Sir, there is a question, sir.
Hello?
Hello.
Not audible.
Are you audible in OT1?
Are you with me or with
Yes, sir.
Dr. Parag?
Sir, we are with you, sir. Sir,
Sorry?
sir, we are with you, sir. There is a question in the audience, sir.
Okay.
Sir, the question is, you have added Xylocan for post-operative analgesia. And you will do the surgery for 3 to 4 hours. And the effect of the Xylocan will over by that time. If you will
So-
use the Xylocan during the end of the
You know,
surgery,
in our setup, we have buprenorphine patch of 10 milligram. So at the start of the surgery, I will ask my anesthetist to stick the buprenorphine patch, and it's very, very effective. That is one. Second, we give local blocks of the costal cartilage block when you are finishing it. So you're giving costal cartilage block, the intercostal nerve block, and the buprenorphine patch. And believe me, with buprenorphine patch and block, the patient is absolutely pain-free after the surgery. Buprenorphine patch is the thing which has really made the difference.
Thank you, sir.
Okay.
OT2, are we audible? OT2?
Hello. OT2, is anybody there?
Hello, this is OT2.
Yeah. Can we speak to the faculties there? Like,
Ma'am, painting and draping is going on.
okay. Yeah. Please focus the camera on it. OT2, please.
Mohit sir, hello.
Hello, hello. Hello.
Hello. Yes, you are audible, sir.
Am I audible?
Yes, sir, you are audible, sir.
Okay.
Hello, 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 hello. Checking. Hello, 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 hello.
Yes, hello. OT2, hello.
Vidush.
Sir, you are audible, sir.
Okay. I'll go on that side.
Yeah, yeah.
Hello. Mohit sir?
Am I audible?
Yes, sir.
Am I audible?
Yes, sir. You are audible.
Okay. So let us zoom on to the ear. Can you zoom? Yeah. Is the view good?
Yes, sir.
So as I explained to you before, the transfixion incision is basically the highest point till which the skin is going to reach the blue line. So after you decide at what point you want to transfix, then you need to start the infiltration. Local दे दो. ये पकड़ एक ना. 24 number needle, please. So I use 2% lidocaine with adrenaline.
This is towel. That is buprenorphine patch. Yeah, we also always do that. This is 10 वाला लगाएंगे. छोटी है, कोई बात नहीं. ठीक है. थोड़ा हम ब्लॉक भी लगा देंगे. नहीं, वहाँ पे भी नीचे भी ब्लॉक लगाएंगे.
So I'm infiltrating the posterior surface of the ear.
Yeah. Right.
And the postauricular skin, where we'll be creating a pocket.
7.5.
Hello. Dr. Bharti.
Yeah. Hello, am I audible? No. Mohit? Oh.
I'm Mohit speaking. Am I audible?
Yes, the volume needs to be a bit more
Volume is low or high?
low.
Volume is low, sir. Hello. Sir, the volume is low, sir. So we can hear you, but the volume is low, sir. They are trying to raise my voice.
Let's wait for a few minutes.
So this is the ear. So almost give me a. So if you look at it around 2 centimeters.
40 monocryl भी ready करिए. हाँ, for chest लगेगा. 10 cc लेके रखिए. Now because the skin in the upper part is very badly scarred, I think it's better to discard this scarred skin, because anyways it's not going to be used in our reconstruction. 15 number plate, please. Thank you.
Meanwhile, we'll go to Mohit and come back. Mohit was
sir,
trying.
we are not able to hear you, sir.
You are not able to hear me?
Parag, you're audible. Mohit was trying to tell something. So we'll just switch to this OT and come back.
Can we switch to OT2 please? OT2 please speak up. Mohit sir, am I audible sir?
Can you hear me?
Yes sir, we can hear you sir.
So this is the helical defect of around 2 centimeters. You can see on the scale, and there is a deformity of the superior crust. There is a loss of superior crust of the antihelix, and this is a contractor band. So what we are trying to do is, see, this ear is stuck with the contractor band here and here. So we are going to give an incision, lift up this thing, free the auricle, and take the skin behind, and then move the scalp skin down to create a sulcus. And we have to take a wet excision from here to bring it together. There is a possibility, if there is a difficulty, one can do angular flap also, but this looks very pliable, so it may just come like that.
OT3, are we audible? Parag sir?
Can you hear me now?
Yes sir, we can hear.
Yeah. So I'm starting to create a pocket for the new framework. Suction please. So again we have to take care that the pocket is not very thin, neither too thick. All this deformed cartilage will be removing. Suction please. Suction please. Suction. 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 Number blade. So I have removed the deformed portion of the ear. Quadri please. So we start with a clean slate. Quadri थोड़ा कम करिए please. $15 करिए. Thank you. Now we'll create a pocket in the upper part for our new framework. Let me go to the other side. ये क्या है? ओके नहीं नहीं suction please suction 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 still use let me check where we have reached little bit more एक ना तुझं डोकं जरा साईडने घ्या सक्शन प्लीज बेटर बघ एक मिनिट सक्शन प्लीज
Parag sir,
yes please
sir, do you dissect only up to the marking or you go a few millimeters beyond that?
Can you talk a little louder? I am unable to hear.
Sir, do you dissect, create the pocket only up to the marking or you go a few millimeters beyond the marking?
We go beyond the margin at least by 5 millimeter. I will show you. Now, suction. Right angle, yeah. Right angle, right angle. Suction, please. Okay. Not visible. इकडे उभा राहा ना. Suction. Okay. When you are done, just go out. Let us see one more time. Little bit here. Suction.
The amount of traction you give, Gauss will help me out.
And इससे एक बड़ा साइज का
ये थोड़ा कम, वो ज़्यादा.
Hello, sir, Parag sir.
You will see the plane
Parag sir,
automatically
Bhandari sir
coming.
wants to speak up, sir. We'll get back to
Can
you,
you see
sir.
this?
Can we increase the audio of the auditorium? I am unable to make out the question that is being
Sir,
asked.
Parag sir, Bhandari sir wants to speak up, sir. We'll
Sure.
switch the audio to OT1, sir.
Sure. Oh, wait मत करो, wait a minute.
OT1.
Okay.
Are we audible?
Yeah, I only wanted to show. Can you see the fascia now?
Suction. Yes, sir. ये निकालिए.
Are you able to see it?
ये ठीक है.
Yes, sir.
I just wanted to tell you I've given a lot of adrenaline. So can you see this? I am not incising. I'm just pushing it, and I'm able to dissect it out from the fascia. Can you see this? I don't know whether it is possible to show
Yes, sir.
them
We can
or
see,
not.
sir.
I hope one can appreciate what I'm trying to show.
Yes, sir, the follicles are not visible. Fat layer is clearly visible over that, and the fascia beneath is very much clearly visible.
Fascia, you're dissecting above the fascia,
Yes,
and you will not be able to see any hair follicle. So that is I was telling in my lecture that the fascicle or the follicles should not get exposed. Can you see this?
Yes, sir, we can see, sir.
So the in between you can show few hair follicles through the fat over here, but not getting exposed. And we are now reaching the artery. Can you see this? This probably would be the artery. नीचे स्किन हुक लगाना है. आपको जो स्किन को ट्रैक्शन देना है ना वो ज़्यादा होना चाहिए, ये वाला कम होना चाहिए. हाँ, जो स्किन पे ट्रैक्शन है वो कम, जो स्किन हुक का ट्रैक्शन कम होना चाहिए. मतलब इट शुड बी टूवर्ड्स मी, नॉट टू मच, वो ज़्यादा होना चाहिए. ये लूज है, ये मेरे वाले में नहीं लगा है, मेरे वाला है ये. हाँ मेरा ही है. ओहो, क्योंकि लूज हो रहा है ना, ये निकल जा रहा है. छोटा है ना वो. उधर उनको दिख रहा है कि नहीं दिख रहा पता नहीं.
We are able to see, sir.
ये आर्टरी ही इधर को आ रहा है. जो फील किया था आर्टरी तो काफ़ी आगे फील किया था हमने, नहीं? एक मिनट छोड़ना. आर्टरी शुड बी हियर, तो उसका ब्रांच होगा ये तो नहीं. ये तो बहुत पीछे है. आई एम ओनली वरीड फॉर द वेन. वेन कहीं पीछे दिखती. चलो लेट्स सी. Retraction. When you give retraction, the plane automatically comes. Yes. Either. In the lower portion, the dissection is much easier because there is a definite plane. But I can't see the artery which I have felt. ये आ रहा आर्टरी बहुत पतली सी, क्यों एडलिन दिया ना, तो एडलिन देने से वो
OT1 will get back to you. Mohit sir wanted to show us something.
Sorry?
Sir, we'll get back to you, sir. We'll shift to OT2.
Okay, okay,
OT2, please.
okay. Dr. Mohit is also operating.
Mohit sir,
all right.
Are we audible?
All right. Okay. ये है आर्टरी.
Sir, your voice is not loud, sir.
I am just trying to take a wedge of this cartilage.
वो दिखा आर्टरी ना. देखो प्रियंका लगा ठीक है, आराम से होता है, इसमें ब्लीड नहीं होता। तुम लोग इंसिजन दे के करते हैं, कट करते हैं। ये आर्टरी और एक
you have because it's a one less than a quarter defect or a maximum 1/4 defect with more than 2 plane. I think theoretically, sir, it is 2 plane 1/4 defect like. So in such cases, you have not preferred to do a conchal catalyst grafts or any limitation you found in this particular case. That's why I have not chosen that plan.
I'm not understanding how do you do conchal cartilage graft in this?
So you have no, so theoretically, when is such case, sir, when you go with only because there is post-auricular skin is scarred. That's why I have not preferred or what. Scarring is there. Lot of scarring is there post-auricular reason.
See, our aim is to create as natural looking ear as possible. And here it is, as you can see, all the dimensions of anti-helix as well as helix are coming up. Although ear is becoming slightly smaller, but the shape will be good with the natural shape. So that's why we are not using any graft.
Or it is the scar present that is the limitation, sir. You are not using or what. So scar is not a matter.
Scarring is not a problem and shape is good.
Okay, sir.
Can we get back to Bhandari sir's OT, please? Hello, Bhandari sir.
लेकिन उसका नीचे तो दिख नहीं रहा ना कोई कनेक्शन।
Yeah, Bhandari sir, we are able to hear you.
ऊपर तो कोई दिख नहीं रहा है।
Yeah, Bhandari sir, we are able to hear you. Can you just explain?
Hello, are you with us?
Yes, sir. Yes, sir. We are able to hear you. Can you just explain, sir?
I'll just show you too. We are trying to look for the vein. I'll show you. Can you see the artery?
Yes, sir. Yes, sir.
So this is the artery which is actually dividing here. One branch is going this, other branch coming until this is the frontal branch, this is the parietal branch.
Yes, sir. We are
this
able to
is
see.
diagrammatic arch, so roughly around 2.5 centimeter above it is dividing.
Yes, sir.
So artery is there, it is looks contracted because we are given lot of adrenaline.
Yes, sir.
So by the time we finish, this should come up. But we are actually worried about the vein. We couldn't find any vein. This I was just discussing here. If the patient has a bilateral microtia, quite often
Yes,
it
sir.
is difficult to find the vein.
Okay, sir.
So let me see. I'm going right up to the posterior auricular area. Maybe you'll be able to. Can you see here? It is absolutely dry because of the adrenaline. Can you see this? Absolutely no bleed.
Yes, sir. Yes, sir. Nice plane.
Absolutely fine, but we couldn't find the vein. So we'll have to find out the vein. And I don't know. See, sometimes happens. Can you see this? There is a scar here.
Yes, sir. Posteriorly there is a scar.
So there is a scar. I don't know what has been done. If there is a scar, and inadvertently, if somebody has injured the vein,
Yeah.
then there will be no tributaries.
Yes, sir.
So it looks like, because can you see the scar? It
Yes,
is
sir.
exactly the
Yes,
same
sir.
area.
Yeah, yeah. Yes, sir. It is.
So
clearly
let me
visible.
find out if you can find any vein over here. And if you can see the undersurface, there is no vein over here. That means we have not raised any vein with the flap also.
Yes, sir.
Show it. There is no vein under surface of the flap. There is no vein over here. If you see it over here, it is absolutely the hairy follicles covered with the flap.
Yes,
Can you
sir.
see it?
Yes, sir. Yes, sir.
And there is no vein here. There is no vein here. There is no vein on the surface of the fascia also.
Okay, sir.
And artery, of course, is contracted because of Wedelin, but appears very small diameter artery. Let me see if we'll be able to find any vein over there or not. नहीं मिलेगा तो क्या करेंगे? We'll like think.
Sir, there is a question to Mohit sir from the chat box. Mohit sir, can you hear us?
कुछ क्या बोला मेरे को समझ में नहीं आ रही.
Sir, there is a question in the chat box to
Yeah,
Mohit sir.
please continue.
Yes. Mohit sir, can you hear me? Mohit sir? Mohit sir, can you hear us? Mohit sir, are you audible, sir? Okay, sir. Getting back to Bhandari, sir. Bhandari, sir, please continue, sir.
You might have to abandon also.
Parag sir, are we audible?
Yes, please.
Yes. So could you please explain, sir, how you are harvesting, sir?
So the 8th rib is being harvested and 8th rib is removed extraperichondrially. So which means we don't have to lift the perichondrium from either the anterior or the posterior surface. So I am just in the process of removing the 8th rib. I already cut it. Can we get a scale? Remove everything. So this is the 8th rib. Let us see the length of the 8th rib. It is roughly 9 centimeter, which should, can you centralize my scale? Yeah. So it is roughly 9 centimeters, which is good enough for forming the helical rim in this case, because the lower part of the helical rim is present. What we need to make is the upper part. So let us keep this in saline. ले लीजिए.
Hello. Sir, Mohit sir?
Right angles. Right angle. Yes, please.
Yes, sir. So Parag sir, Mohit sir is trying to speak something, sir. We'll just
Sure.
get back to you, sir. Mohit sir, are you audible, sir?
Am I audible?
Yes, sir, you are audible, sir.
So see,
ये तो चांस लेने वाली बात है कि we raise the fascia without vein,
join the cartilage to cartilage. There is a good
and then the fascia goes off along with the cartilage. No,
this scalp skin we are going to move and attach it at the end of the sulcus.
I will leave.
You won't do it. We complete the reconstruction. You will have a good shape, although it will be smaller. Because the other ear is totally missing, so there is not much problem in this situation.
Okay, sir. Mohit sir, there is a question to you from the chat box. They are asking, can you please demonstrate how you have mobilized the root of the helix, sir?
Root of the helix, we have just given incision here, and that's it. And then this skin we have sutured behind. The skin which was here, we have sutured behind. That's all.
Okay, sir. Thank you, sir.
Create the posterior auricular surface.
Parag sir, can you hear us, sir? You can continue, sir.
Am I audible?
Yes, sir, you are audible, sir.
Yes, please. I am now separating the perichondrium from the seventh rib, lateral aspect, gauze piece. So we are going to harvest the ribs in such a way that the anterior perichondrium is taken along with the rib, and the posterior perichondrium will be kept inside. So I made an incision. Can you see the white glistening thing? That is the perichondrium.
Yes, sir.
Then we introduce left gouge. No, it's okay. In this pocket to free the perichondrium from the under surface of the rib. Now we free the perichondrium on the upper surface of the direction has to be like this. Periosteum, suction, suction, okay. Let us take the left side. Left side. Show me the lower part. Suction on the upper part. #15 blade. Okay, don't move. ब्रदर लगाना पुल करो उत्सव ये बरोबर नहीं है सेक्शन ये दिसतच नाही आम्हाला राइट साइड दे देखते हैं ऊपर से डाल के देखते हैं सक्शन के नहीं ओके कॉटरी पकड़ो लॉन्ग फोर्स से दो
Mohit sir, your voice is very low, sir. Sir, the voice is very faint.
Yeah, I am coming to you in 2 minutes. I'll speak loudly and I'll show you the photos also.
Yes, sir. Yes, sir. Yes, sir.
I'm coming there.
Parag sir, can you hear us, sir? You can continue, sir.
Am I audible to you?
Yes, sir, you are audible, sir.
Okay, so I have cut the 7th rib at the lateral end. Now we are going up to the 6th rib, careful. And because he is an adult, the rib stock is quite nice. So the thickness of the rib is good. You don't need to put a projection piece if the thickness of the rib is good. 15 number blade. So first we incise the perichondrium on both the sides. छोड़ो एक मैं लगा के खींच देना मतलब. Yeah, hold this one. That is better. It's okay. एक ना लाओ. See, you have to be on the rib. You are going above the rib. I am not working there. I am working here. Yes, be there. Okay. So I am making an incision on the perichondrium, upper end and lower end, periosteum elevator. Suction, please. Suction. Suction. Now the lower part, lower end. Right side. Suction. काय करतो? So you can see my instrument has come out from the lower end.
Yes, sir.
Is it visible?
Yes, sir. It's visible, sir.
So now I am going to cut the lateral end. Cautery, please. So let us shift Utsav a little bit to this side. Relax Utsav. Hold like this. नीचे का retractor किधर है? खाली. वरती खेचू नको. Cautery. थोड़ा ऊपर. Okay. टेबल का हाइट बढ़ा सकते हैं थोड़ा. अभी 2 टेकाडम ले लेंगे. स्टॉप. 2 टेकाडम फिल्म्स. Now we are going to take our template and check where the upper end should be, upper cut on the cartilage. So let us take our template and see. Okay. Okay. Remove this also. कौन दे रहा है टेम्पलेट? ये हटाओ, यहाँ मत रखो. इसका बीच में बराबर से रखिए. Can you focus on this? Little up. Yeah, perfect. Yes. इसके बीच में रखिए. रख दीजिए बस. So I have taken my template and I am going to wrap it between 2 Tegaderm films so that you have a template which is sterile on both the surfaces, and then you remove the excess Tegaderm. Keep a small margin of few millimeters on each side like this so that it is completely sterile. Artery, please. Right angles back. So let us place the template that we have made. Now on this template, if you remember, there is a horizontal line. Can I get a marking pen? So we have to make a framework till here. Is this line visible to you?
Yes, sir. Visible, sir.
Because the patient has the lower part. So when I am placing it on the base frame, this is roughly marking pen. This is roughly coming till here. Roughly till here. And plus we'll take a centimeter or so for a small piece, maybe for the second stage. Take this, ये trolley पे रखिए, ये important है. So let us free up the cartilage a little bit more. It has yes. Let us incise here. Suction, please. Periosteum elevated. लाइट थोड़ा एडजस्ट करेंगे. Cautery, please. Hello.
Yes, sir.
Can you hear me in the hall?
Yes, sir.
Yes, sir. You are audible, sir.
Okay, I just wanted to show the superficial dissection has been done. Can you see it here now?
Yes, sir. We can see, sir.
So there is no bleed because we have given lot of adrenaline. Can you see this? Absolutely dry.
Yes, sir.
एक artificial देने का.
Sir, what is your normally what is the anterior limit of your dissection?
Limit of?
Anterior limit of raising this superficial.
Anteriorly, I told you the marking of the frontal branch of the facial nerve around lateral limit of the eyebrow, around 2.5 centimeter here, 2.5 centimeter, and just above the tragus. This is a line.
Okay, sir.
So you don't go beyond that. Can you see this? We have reached right up to there.
Okay, sir. Yes, sir.
Yes, sir.
And superiorly, can you see this? From here it is turning. The plane is changing here. And you can appreciate little pinkish here and this
Whitish.
portion is little whitish.
Yes, sir.
Can you see this?
Yes,
Yes, sir. Yes, sir. Clearly visible.
This is the limit of temporoparietal fascia. Now this is the extension, random pattern. This is slightly color change. So I think this much will do. If you can see it here. So this much would be the fascia. Can you see this?
Yes, sir.
Yes, sir.
So here is a small. So this much will do. Right?
Yes, sir. It looks sufficient.
The only thing which I wanted to tell you, आर्टरी दिया मुझे एक आर्टरी दिया, मॉस्किटो दिया, अच्छा, इधर भी डबल लुक लगा दो. So this is the parietal branch of the artery. Can you see this pinkish?
Yes, sir.
This is the, it appears it is dividing. This is the frontal branch.
Yes, sir.
This is the parietal branch.
Yes.
We couldn't find any vein except this vein which is lying here.
Yes, sir.
And we could not trace it. It is ending here. We can't find any vein in the flap. Maybe inadvertently we have raised it, but there is no vein over here. Can you see this?
Yes, sir. That is only fat.
Absolutely no vein. Also here no vein. No vein here. So this is the only vein we are relying upon because we have gone right posteriorly also. And I'll show you there is no vein in the flap. Can you see this flap?
Yes, sir.
We have in fact gone little superficial here thinking that there will be vein, but there is no vein. So this is the artery, this is the vein. I believe this is the only thing which we can rely upon. I was just thinking whether we should go ahead or not because the vein is probably deficient because of the scarring and whatever somebody has done before surgery, in the first surgery, that there must be some injury to the vein. And if the main vein is injured, then the tributaries also shrink. They will divert to some other direction. But this is a vein probably we can think of. Can you see this is very superficial?
Yes, sir.
So this is the only vein. So this much flap we have raised. You can see the artery, anterior and posterior branch. This is the vein, absolutely dry, no bleed, right? So we are now raising this skin and will be taking out the cartilage from here, which will not be used. इसकी नहीं कुछ लगा दो, forceps भी देना मुझे एक, इसकी नुक लगा दो, it's not working. एक पेरियोस्टम एलिवेटर टाइप कुछ है अपने पास में, मतलब फ्रीयर्स टाइप का, फ्रीयर्स है अपने पास में. ये तो बहुत ब्लंट है, दिस इज वेरी ब्लंट. मेरे वाले में होगा एक, वो दे दो. नहीं वो एक ब्रॉड सा है आगे से.
Sir, can we move to Parag sir's OT, please?
Okay, थोड़ा स्टूल आगे कर दें.
Parag sir?
Am I audible?
Yes, sir.
So, placement of the base frame on the harvested cartilage. So we need a portion which is wide enough to accommodate the entire base frame so that we don't fall short here. So this seems to be the correct place where I can position the base frame. The portion which is above this we can use for the Y.
Yes, sir.
This piece we can keep for the second stage, and there is also going to be a piece here which may remain.
Okay,
so that also can be an option for the Y.
Okay,
so
sir.
this is the cartilage that we have harvested. It has mainly the 7th and a little bit of the 6th, and the synchondros is between the 6th and the 7th. So in his body it was like this. So the anterior perichondrium is preserved.
Okay,
and
sir.
will be carving on the posterior surface which is devoid of the perichondrium. Okay?
Okay, sir.
Keep it in saline, please. Thank you. Okay. 20 Vicryl. Let's check for hemostasis. Paratla. Can we adjust the light inside? Yeah, perfect. Thank you. Good. Utsav, relax. There's some bleeding here. Okay.
Sir, we have a question from the audience, sir.
Parag sir? Parag sir, is audible?
Am I audible?
Yes, sir. So you do check for any, do you tell a anesthetist to do a Valsalva before closing or?
Always. We'll be doing that. I'm just looking for some hemostasis.
Okay.
नीचे का पार्ट देखो. Looks okay. Saline anesthetist कौन है? Relax, बिना देखे मत डालो. We'll be doing Valsalva maneuver. You have to take on hand and give positive pressure. I'll tell you. Saline, please. Thank you. Yeah. So I'll be pouring some saline. Can you blow, please? Put a right angle. Are you blowing? Yeah. So the anesthetist is giving positive pressure ventilation. I have poured some saline inside the dissected area, and we are watching for any bubbling. You are blowing. So all seems to be good, and I'll remove the saline now and we go back on the venti. Remove. Any questions so far?
No, sir.
20 Vicryl, long tooth forceps.
Sir, have you encountered any injury in your practice, sir?
Yes, you can have injury to the pleura sometimes, but then it is not a cause for worry. Don't right angle now. Because even if you make a small nick in the pleura, it is the parietal pleura, not the visceral pleura. So you can just suture it back and put a small piece of muscle to cover that rent, and you don't need to put an ICD. I have never had to put an ICD in any of my patients. So small rents you can manage just by direct suturing. Of course, the greatest advantage of keeping the posterior perichondrium behind is that you are keeping the pleura intact. There is an additional layer between the pleura and your dissection so that you are safeguarded. Can someone do suctioning? Okay, let's see the lower rib. Lower rib, lower rib, lower rib. Suction to me.
Do you use frequently buprenorphine patch for this post-op management, sir, of pain?
Yes, I put sometimes fentanyl patch, and I routinely infiltrate the muscle closure with ropivacaine, which is what we'll be doing after closing the rectus sheath.
Sir, any long-term complications you have encountered with this in the
Long-term problems of deformity of the chest wall?
Yes, sir.
No, I have not encountered any problems with deformity of the chest wall, even in bilateral cases of microtia where we remove cartilage from both the sides.
Or any patient complaints, sir?
Sorry?
Anybody has complained, if patient has complained about pain or any
I think adults keep complaining of pain. Adult males are the worst. They keep complaining of pain sometimes for almost up to a month after the surgery. Children are the best. Within 1 week they have forgotten that anything has been taken from the chest. And I think if you stop short of the xiphisternum, then there is no chest wall deformity that happens in the long run. So I am closing the rectus sheath, and I will infiltrate ropivacaine in this. Can you get some ropivacaine? You can give also an intercostal nerve block, or your anesthetist can give an intercostal nerve block if they are good at it. Hmm? मॉप करो ब्रदर.
Parag sir, there's a question in the chat box, sir.
Yeah.
They're asking how to mark the ribs on the skin beforehand, sir, pre-operatively.
You just need to palpate, so you will feel that there is a rib in the lower part of the rib cage, which is free from the upper rib. So that is the first rib that you need, which is the 8th rib. 7th and 6th, you can't really, when you push it down, you can't really feel that it is separate from the upper rib. So that is the synchondrosis. Ropivacaine. Kitna cc hai? So when you palpate, the first rib which keeps moving is the 8th rib, because it is free here. There is no attachment between the 7th and 8th, at least not a strong attachment. And then when you try to go one step higher, between the 6th and the 7th is the synchondrosis. So you can't really, delineate the difference between these two. So this becomes the 8th, then the 7th, and then the 6th. Cat's paw कितना परसेंट है? नहीं 0.5%, 0.25. ये कितना cc लिया है? 10 plus 10 okay. So we are infiltrating 10 cc of ropivacaine, 0.2% with 10 cc of saline, so a total of 20 cc. I am injecting it in our suture line. And some of it I will infiltrate in the subcutaneous plane. कोर्से पे वाइक्रिल दीजिए. So like what we did yesterday, we will not close the entire length of our incision. We will keep a small 1 centimeter gap. So I will bank a small piece of cartilage for the second stage. Jelly loud. So I find that this oblique incision heals. And patients generally don't mind an incision which is very well concealed, or it's a fine incision. Jelly.
Sir, we are going to Bhandari Sir Theatre. We'll come back to you.
At the carving, yes.
Bhandari Sir. 41, it is audible.
ये गॉज इसके ऊपर रख लो एब्डोमिनल माउथ.
Who's the
चलो हम रिट्रैक्टिव लगाएंगे.
कर दो प्लीज. ओके, कार्विंग के लिए कौन सा टेबल लेंगे? कुठलं?
मार्क करेंगे नाइफ देना, एक मिनट थोड़ा सा और रेज करना चाहता हूँ आगे. सी वंस यू कट इट द anterior margin becomes very close to the artery, so when you are suturing it you can probably थोड़ा सा कम injured. ये है ना आर्टरी, थोड़ा मेरी तरफ खींचो उसको टुवर्ड्स मी. हाँ अभी वो खींचो, लाइट नहीं आ रहा. बहुत खींच दिया, उठ गया पूरा फेशिया. डन. लीजिए पेन देना. So this is the artery which you are marking. उसके साइड में किया ये वेन है. This is another artery. ये तो कटेगा ना अगर यहाँ से. And the incision would be like this. यहाँ पे you'll have to ligate the artery. 40 या 50 Vicryl लेने का है. Take a little extra. This may not be required. अब क्योंकि वेन है नहीं ना, मैं थोड़ा ब्रॉड पेडिकल लेना चाहता हूँ. राइट, तो कैन यू मेजर दिस नाउ?
Parag sir, can you hear us, sir?
स्किन हुक है.
Parag sir. Hello.
Yes. Am I audible?
Yes, sir. You are audible, sir.
So I am removing the muscle attachments from our harvested ribs. So if you look at it in the patient's body, this is how the ribs were. So we have preserved the perichondrium on the anterior surface between the 6th and the 7th. So it gives an additional stability to this synchondrosis. And of course the 8th is removed extra perichondrially, so there is perichondrium on both the surfaces. Now the carving will happen on the posterior side. So we have to make the right ear. So this dimension of this conforms perfectly with the right side. 15 number blade. So we start removing the muscle attachments from the rib cage. Periosteum. Let's remove all the muscle attachments from the posterior surface.
Parag sir, I have a question.
Yes, sir.
So, what are the extra instruments we require for this ear carving?
I will show you the gouges that I use.
Yes,
Just
we
give me
saw
2
yesterday.
minutes.
Apart from gouge and other things?
Apart from the gouge, I use 15 number and 10 number blades. That's it, nothing else.
Thank you.
15. पकड़ो. Done. You can take something to sit, don't stand. Sit. Okay, this looks to be okay. Let's dry this. Pattern. So I'm going to mark the base frame. You can zoom in a little bit. Marking pen. So this is the best place to make the base frame because this is the broadest part of the synchondrosis. So we don't want to end up in a scenario where we need to add an extra piece here. So you choose the widest part of this synchondrosis. The lower part can be changed as per the requirement because if you keep it here, it may fall short at the lower point because the width is less. If you shift it slightly higher up, then you get adequate width even at the lower place, because this is what I want to tuck inside into the lobule. As you saw that we have created a pocket there, so I would prefer to have this as the uppermost point. 15 number blade. Number blade. Marking pen. आपल्याने मार्क ओके नाइफ नीट लावून ठेव. You have to make sure that the framework that you carve is not bigger than the size of the opposite ear. So you keep on comparing with the pattern that we made, because marking please, the skin envelope is going to create additional layer of thickness. You need to take that into account. So we definitely don't want to exceed the size of the reconstructed framework by a few millimeter. It's okay if it is a few millimeter smaller, but a few millimeter bigger is something which will stand out. It will start looking bigger than the opposite ear. Number. So this point has to be little low. If you see it in the profile, this is quite high, and as the helical rim ends, it has to be the lowest point in the framework. So I am going to lower this height a little bit. पकड़ो. काय ब्लेड आहे हे? टीवी से. As compared to yesterday's child who was 10-year-old, this is an older patient, so the cartilage is slightly stiffer. Then I also want to lower the lower part of our framework, because this has to be tucked inside the lobule, so I don't want it to be too thick. It has to be thin enough so that I am able to tuck it inside the lobule. So I am lowering the height. दस नहीं है. So I've lowered the height of the uppermost point also and the lowermost point also. 15 number blade.
उनको बोलो जरा. Hello. Hello, can you hear me?
Yes, sir. We can hear you,
Yes,
sir.
sir. Yes, sir.
So can you see this? We are raising the fascia and you can see the deeper surface. There is a definite plane of cleavage. Can you see this?
Yes, sir.
Absolutely clean,
Yeah, it's very clean, sir, without any blood.
deep temporal fascia. So I am raising the flap over the deep fascia, deep temporal fascia. And there is a definite plane of cleavage. Can you see this?
Yes, sir.
So we have marked the artery and we are going beyond that. We have already ligated the anterior branch of the. Okay, so can you see this?
Yes, sir.
So fascia is coming here. So we want to make a little supraauricular groove also for the for where the frame can rest of the spectacles. And can you see the vessel middle temporal artery over here? Can you see this?
No, it's not appreciable.
This is this is in the deep temporal fascia.
We can decrease the brightness.
This is branch. लगता है ना? नहीं छोड़ दिया जाए उसको फिर है ना? इधर रिट्रैक्टर लगाओ. ये अरे ज़्यादा कम कर दिया. छोड़ दो. So the fascia has been raised. Now we'll go for the cartilage. So this is the fascia. You can see here the artery and the vein. ये ले. माप डाल दो उसके अंदर. The middle temporal artery, or deep temporal and mid temporal artery. So we are through with the fascia. We'll now go to the cartilage part. इसके बाद एक gauze कर दें.
भंडारी सर.
It can be normal saline now, क्योंकि वो vessel फिर contracted रहेगा ना. Normal saline वाला दे दो.
Bhandari sir?
Yeah?
So do you put any papaverine soaked gauze or to dilate the vessels, or you put a normal saline only?
So initially it was Xyloquine with adrenaline. Now I'm putting only normal saline so that by the time we are through with the cartilage, the effect of adrenaline would have gone. Okay. Right?
Yes, sir.
I'm going to that side.
Sir, how frequently do you encounter this no vein when you raise it?
So that is the inframammary crease. Cartilage is quite low, but then I want to give inframammary crease incision. It becomes a little more difficult, especially in female patients. So you'll need monopolar also. Knife. I give a big incision because the incision is way away from the cartilage. कितने पे ज़्यादा तो नहीं क्या?
सक्शन काम नहीं कर रहा है.
एब्डोमिनल मॉप भी वेट करके दो यार. ये थोड़ा ब्लंट वाला दे दो, ज़्यादा शार्प है ये.
फ्लैट टिप चाहिए.
हाँ फ्लैट टिप दे दो.
जो दूसरे टिप है ना, पॉटरी का.
हाँ वो दे दो. ये लो, क्योंकि इट विल नॉट वर्क यहाँ पे वो ये ब्लेफरोप्लास्टिक ले ठीक है. Skin looks like वो cat spot type.
Parag sir,
Yeah.
so do you have different sizes of gouge or?
अच्छा ओके. थोड़ा ज़्यादा बढ़ा सकते हैं क्या?
Small, medium and large.
उसको थोड़ा सा ज़्यादा निकाल दो. ये कवर जो है ना ज़्यादा किया है. थोड़ा सा उसको ज़्यादा निकाल दो. और पावर भी बढ़ाना है. Yes. रिट्रैक्टर्स ले लेना भाई.
बड़ा है ये.
अभी ना वही लगा दो. अभी कैट्स बॉय ठीक है. अभी वर्टिकल. So we have to go lower down. So we'll dissect the things and then cut the cartilage. वो muscle over there. Direct incision तो सीधे काट जाते हैं ना. इसमें तो we have to go little lower down. उठाना. I think I'll come to your side. चलो उठाएं. कैट्स उल्टा ही लगा. थोड़ा सा टेबल रेज कर देना.
टेबल रेज कर दीजिए.
इधर रिट्रैक्ट. स्किन रिट्रैक्ट करना होता है.
रिट्रैक्टर
ये ऐसा.
अप करना है, डाउन.
थोड़ा सा
अप करना है, अप. थोड़ा और करो.
ठीक.
ठीक है.
कार्टिलेज बहुत नीचे है. इसका थोड़ा डिफॉर्मिटी भी था ना इसमें. कार्टिलेज बहुत नीचे है इसका. You can feel the different cartilage. ऐसा. There's a little more convex.
Am I audible?
Yes, sir.
Yes, sir.
So this board of mine has a scale. So if you see the length of the 8 rib, it's around 9 centimeter, which is good enough because the lower part of the helical rim is already present in this patient. So this should be sufficient.
So this A3 minimum 9 centimeter is always good for our carving. Helical rim.
For the helical rim, can you repeat the question?
Sir, what is the minimum length of A3 to be taken so that the helical rim can be done, sir?
Normally for microtia you need at least 10 centimeter, 9.5 to 10 centimeter.
Okay.
For post-traumatic cases, it depends on how much of the helical rim is damaged. 10 centimeter is a good length.
This board of yours is very good, sir.
The board is good.
Yes, sir.
Thank you.
The price?
It is not very expensive. It is available in normal stationery shop.
It's a hard plastic.
It is rubber actually. but it's autoclavable. And it has a grid, so I like that I can keep checking the size. Mota. So now I'm going to thin the thickness of this 8th rib because we want it to curve. ये काढ़ा So you have to thin it, but just thin it enough that it doesn't break, and also it should have some sort of thickness for us to place the stainless steel sutures base frame. So this is how it will be when we fix it. Let me thin it a little bit more. Yeah, roughly 1.5 millimeter to 2 millimeter. 3 is too thick. पकड़ेगा ना? Yeah. छोटा गाउस दे. Yes, so this will form the helical rim. Now let us carve out a piece for the Y of the anti-helix, 15 number blade. Now because he is an adult and the native cartilage already has a good thickness, we don't need too thick a piece. So this much thickness I think should be good enough. Plus the anti-tragus is already present. So I will keep this particular piece for the second stage, and this will be banked in the chest cartilage for the second stage.
sir, dimensions of this part cartilage to be banned?
It really depends on what remains, but in this case it is around little more than 3 centimeters, sir. Here.
3 centimeter maximum width.
Parag sir, there are a few questions in the chat box.
Yeah.
So first question is, which brands goose do you use, sir?
This is from Karl Storz, and this has been designed by Dr. Fermin.
And sir, second question is, what is the thickness of the helical rim, sir?
So the thickness of the helical rim, if I can show you like this, is it visible?
Yes,
Can
sir.
I get a scale? At the highest point it is around 5 to 6 millimeter. Let us see. Let us check this. So it's around 6.5, 7 millimeter in the highest point, and of course it tapers on either side. Marking pen. (23). So I am going to lower the height of both the limbs of both the crura of the Y of the antihelix. Fifteen. पकड़ो. Small gauge. So the scapha at the narrowest point, it should be at least 4 millimeters or 5 millimeters, and of course the scapha should be wide enough to accommodate the skin. Can we take a photo? एक iPhone सांग कुठे. So let us see the components what all we have created. So because it's a partial framework, we don't need the anti-tragus or tragus. So these are the three parts. Let us take a photo. Upload kutte phone. Take in your phone first. Can you take in my phone also? हाँ just open करना है अंदर स्टेराइल है. Take without flash. Yeah. That's okay. Cool. Light on. 15 number blade. So I'm going to lower a little bit the lower crust of our Y because it's a little too high. And the upper crust just a little bit, upper crust is okay. Small gouge. Forceps. Then of course you have to smoothen out any sharp edges. Okay, now let's start fixing first the helical rim. So I use stainless steel wire sutures to fix the different components of the reconstruction. Can I get a marking pen? The rail pen. Because it should pass through both the upper and the lower piece. So our Bhishma Pitama is getting ready for 15. To lower slightly the height here. Fifteen कदी change करें? So the stainless steel sutures give you a lot of stability, they give you a lot of rigidity in terms of the fixation. So you are not worried about any part moving later on as the skin starts to contract. And this is what I like about the stainless steel sutures. So let us tighten these wires now. So as I showed yesterday, all the knots are tied on the under surface. Similar to how you create an IMF.
Parag sir.
Yes sir.
Yeah, the way you are fixing the wire sir, it will remain in the posterior aspect. And by that I think it will prevent exposure to the skin surface. That's why you are fixing posterior, no sir. You get my?
It is adding to the thickness you are saying?
No. The wire you are fixing, the knot you are putting on the posterior aspect. So in that way, in the anteriorly, had it been there in the anterior aspect, so the chances of sinus formation is more.
Yes, the knots always have to be on the posterior aspect.
Yeah, that is true.
And when we cut the ends of the wires, I will show you how to bury the suture knots into the framework so that the chances of extrusion are minimized. But see, even if there is a extrusion of any of your stainless steel wires, it is not a big thing. You can just use a mosquito forceps and pull it out. Nothing happens to you, the rest of the framework.
Okay.
When you tighten the knots properly and when you bury the ends properly, the extrusion rate is less than 1%. So if you have used 100 wires, you will have one wire causing a little bit of issue. It is not something which happens in each stainless steel wire that you use. So extrusion is more theoretical than actual. Doesn't cause any problems actually. To make the entire framework, normally we need around 3 packets. Each packet has 5 wires. But because it's a partial framework, I think we'll need 2 packets for this case.
So can you tell us the company name, sir? Again, sir.
This is manufactured, the one I'm using today is manufactured by Auro Lab.
So we have to specifically tell about the straight needles.
Yeah, it has 2 straight needles, one on each side. And the stainless steel wire is 40. It is the same thickness as a 40 ethylon.
So that is same as that of 32 gauge, sir.
I think it is thinner than a 32 gauge slightly. There is one company in Turkey which manufactures straight needled PDS sutures. So there is a PDS suture and a straight needle on either end. That comes in 40 and 50 sizes.
So you have always used the stainless steel wires, or
Yes.
previously you are using this PDS?
PDS very rarely I use, but I use stainless steel in all 100% all cases of ear reconstruction.
Any other cases, sir, you use stainless steel? Use is there?
I'm sorry?
Any other than ear reconstruction, anywhere else we can
No,
use
only
stainless?
no. I don't use it anywhere else. Mainly in ear reconstructions. So you see, it gives lot of stability to your framework. No matter how strong the contraction forces are, this is not going to move. This is not going to move. So I'm just going to use a knife to smoothen out the excess parts of the cartilage.
Sir, is any experience with Prolene, sir? Because we're not getting wire. Sometimes you use Prolene only, and the chances
No,
of
I hate Prolene. I don't like Prolene.
No, that's not your experience with Prolene, if at all you have used.
No, I have never used Prolene. But I feel it doesn't give a very stable fixation.
Yeah.
So, yeah. So the helical rim and the base frame is ready. Now let us let us fix the Y to this reconstruct. It's a little stiff at 1.15. So I'm going to thin it slightly so that it curves a little bit more. पकड़ थोड़ा और पकड़ marking pen. So we will cut off the excess part of the Y. Let's see how it looks when you fix it. So as I explained to you yesterday, if you look at it in the profile, marking pen, this is the highest point on the antitragus. So the adjoining point on the helical rim is the highest point on the helical rim, and beyond this then it tapers on both the sides. The helical rim will also taper downwards. The roots of the two crura of the Y will also taper downward. Now I want to taper this part, the lower part of the Y. So I have fixed two wires. Now I'll reduce the height of this part. So that also reaches the baseline. And I'll also smoothen out the edges. We don't want any sharp edges on our cartilage. Okay. Let's fix this now. Or you will do it at the end. We'll do it at the end. Just keep a betadine gauze. So let us fix these wires now. So same way, knots on the under surface. So once I tie these wires, I will show you in all the angles the thickness of the framework and the depth of each component. Let me just cut these wires off. Gentamicin ले लो 15 number blade. So again I am burying all the knots on the under surface. Yes, so marking pen. If we see the framework, this is the highest point of the framework. Let us see the depth. Can I get a scale? So this is roughly 1.2 centimeter. That is the depth of the concha. And then if you see the depth of the highest point on the helical rim, it's also 1.2 from the base to the highest point of the helical rim. And then the framework tapers at either end, the root of the helical rim and the base of the Y. So this is what it is, 23. There is just a place where I want to trim the base frame slightly. Any questions for me so far?
No, sir. Hello, Parag sir.
Yes, sir.
We are just starting the Mohit sir's talk.
Sure, sir.
We'll
Sure.
we'll
Please
get
start.
back to you after 15 to 20 minutes.
Absolutely, absolutely.
It is okay, na?
छोटा गाउस दा. पंद्रह दिन.
I would like to invite Dr. Prithviraj Singh sir and Dr. Bishwajit Mishra sir onto the stage as chairpersons for the session.
Hello. So, Professor Mohit Sharma will start his presentation regarding auricular reconstruction. So, I think most of the audience knows Mohit sir already, and he has also done a workshop. So, he is going to present. So, we are delighted to hear your talk, sir.
Thank you, Vishwajit. My special thanks to Dr. Sanjay for organizing such a good workshop and taking all the pains to make it a very good experience for all the people who have been attending it. So without taking too much time, I'll quickly cover some considerations regarding microtia, the traumatic cases and secondary cases very quickly. So this is our hospital, and coming to the classification of microtia, see this Nagata's classification is based on the, like you classify it so that the type of defect determines your technique. So there is a lobule type, you are going to use a total framework reconstruction. If in the concha type you have a canal present, and you can use the transfixion incision and use the lower part of the framework which is available and make only the upper part. In small concha type, you have no indentation of canal, so again you may use a total framework reconstruction. Then there is anosmia. Again you will create the all the components of the framework. And there is a way of tackling the low hairline atypical microtia that we'll discuss. So preoperative marking, if the face is if the face is normal, then you can just take the replica of the other side and transfer it to the affected side, and you can get the position of the ear. But this is for the normal side. You can take all the landmarks. You can take from the lateral canthus to root of helix, from the angle of mouth to the lobule, and match it to the opposite side. But if the face is contracted on one side in hemifacial microsomia, then generally the best way is to have a compromise and keep it one index finger behind the sideburn, the root of helix. That gives a reasonably acceptable appearance, because you cannot lengthen the face on that side. Or you can do it by preoperative, like before that you can do a distraction osteogenesis of mandible and try to optimize the situation for the patient. But if a patient comes like this and you have to do auricular reconstruction, then you take a reference of the sideburn to have a optimal position. So this is the stage 1 and of Nagata technique, in which you just reconstruct the framework, lobule transposition and tragal reconstruction, and in stage 2 you do the elevation. And these are the instruments we demonstrated. They are very good instrument developed by Medicon company on the guidance of Dr. Nagata. And these elevators are especially useful, and we were missing that. There's no pointer? Is that a pointer? Just wanted to say, this is a elevator which can cut and elevate also. So this is good for adult patient. This is not there in that set. And and this is also not there in that set. This is also for cutting and elevation. Only this one and this one is there. These are the atraumatic ones, and very good for elevating. Very rapidly you can elevate. And these are the respiratories which are useful. This is also a atraumatic elevator. So these 5 elevators should be there, and the life becomes easy. Previously we are using stainless steel wires, which we told Aurolab to develop. Then we told them to develop nylon sutures, but then they stopped making it. And now with the Sentinel company, I think the number has been shared in the group. So they are making it. We used those sutures yesterday and they were quite okay. So I think we can just contact the vendor whenever we need. It's a straight needle 4/0 nylon, and it also works for a harder cartilage also. So coming to the lobule type microtia, after I've gone through Dr. Fermin's way of doing it also, and then still keep the approach flexible. Sometimes if the conditions permit, we can use Dr. Fermin's technique also. And mostly I've been using Nagata technique, in which the most important thing is to maintain this subcutaneous attachment here. That maintains the blood supply of the skin here, and it creates a conchal that we'll see in the video. So you split the lobule like this, and then leave this portion attached, the lower portion you leave it attached. These are Dr. Nagata's diagrams himself, and he has been a proponent of using these fixing sutures and this thing. In my final understanding, it is not required, because it is not very essential to develop initial great definition. If the framework is good and there is no hematoma, the skin will drape 100%. There's no doubt about it. So there's no pressure. You should not be under the pressure to generate a contour immediately. If there is no hematoma, the contour will come in 1 month's time.
So I'll just take you through this. This is a typical lobule type microtia, and then this green is the portion where we maintain the subcutaneous attachment, and it is the conchal region. And you just put a template. So we have discussed about that if the ear, opposite ear is 60 millimeter long, your template should be 56. So 4 millimeter is smaller than the size of the ear. Also, we use a standard template, not based on the opposite ear always. Just length is taken into consideration, but not the whole width, because every ear is highly variable. And when you are talking to a person, like if you are looking at me, you will be looking at a time one ear only. So more or less the ear looks like a ear, and it is in the appearance is good. The people are happy. So it's very difficult to match exact contour of the opposite ear every time. The technique will keep on varying. So just to standardize and learn a very good way of doing ear reconstruction, we have just zeroed on to using the same template every time. So we use tumescent solution and then split the lobule. This is a delicate part. You just have to make sure that even the smaller vessels are should remain intact. Otherwise, there can be a chance of some necrosis. And we take 6, 7, 8, 9 costal cartilages. So this is the 7th, and this is the 6th. This is the 6th. So they form the base plate, and once the base plate is formed, then you put the helix on top. Many of the times, if you want to create a proper helix, you have to join another piece here, and which is needed many of the situations. And then this is the tragus creation. So tragus is also created, and the most important thing to get a good definition is there should be good intertragal notch. And then you carve out a tragus, and then this is after creating the tragus, you create the third layer, which is a conchal piece. So conchal piece is carved out on this thing. It just comes behind the cavum concha and this the cymba concha and cavum concha, this region. And then this is finally placed on the undersurface and sutured. So we achieve a three-dimensional framework, which is almost around 18 to 20 millimeter thick. So then you have to have a very good and robust skin pocket. So this is how it looks. In my understanding, whenever we initially were using stainless steel wires only, helix can be covered by TPF and it may not extrude. But in these regions, oh, this is not right. In these regions or some of the other regions, they keep extruding after 4 or 5 years, and then creates a problem for the patient, so we have stopped using it. And this is after placing the framework and lobule transposition. And we are using the 16 gauge cannulas, one in the scaphoid fossa, it goes here, and one behind the framework. Yesterday we used only one, and this is how it looks when it settles. So although this attachment which was kept there, it just goes down and gives a semblance of a pseudo canal. And are you able to see? You may not be able to see from there. You can shift there if you are not able to see. So this is how it just comes and settles nicely over a period of long duration. Now if the primary projection remains very high, we were not using elevation. But then after following up patients for 5 years and 6 years, we realized that it does go down. Even in adults, the slow resorption keeps taking place. And Dr. Nagata, in his personal communication, he was all the time telling that if you do not cover the helix with the TPF, it will resorb over a period of time, which is actually true. So it is good that as long as the framework is good, it should be covered with temporoparietal fascial flap, because in this situation, all the perichondrium has been removed and cartilage is mostly devoid of blood supply. So it is good if it is some vascular tissue comes on top, it remains good. So this is the projection without elevation, and this he needs elevation now. This is another patient. So just the same kind of framework creation technique, and you can achieve quite good initial results. This is a type of framework. For everything we have used this nylon only. So these are some examples. Just give a muscle splitting incision and then lobule splitting incision, then this framework, 3-layered framework, and this is how it should come. It should always be good intertragal area where the skin can drape, and then you just transfer the pedicle and put the split lobule on top, and it gives a definition. So if sometimes we are not confident about removing some nubbins, we can do it later on under local anesthesia, and it settles very well. And this attachment always gives a impression that there is a very good some canal is going underneath, and it gives a good outcome. And those kind of atypical patients, Dr. Parag saying, like, this is a Dr. Furman's way of doing, but one should not assign any particular, keep on assigning name to it, but it's a general thing that lower part of the ear is normal or is present. So you can just give a transfixion incision and then just attach it to the posterior to posterior skin, and then make the framework for the upper part, and this is how it comes, and it can be elevated after some time. Also, again, when we are talking about the transfixion incision, we can just make the framework, and after making the framework, here the whole lobule is free, it is just transferred back. This was, as a unique case, a patient wanted to immediately wear earrings, so we did like that. Again, the lower part of the ear is present, and there is some split lobule also, and we can make the framework which is required in the upper portion and discard the deformed cartilage in this region. So we just made whatever was required, and after making this, we just fitted it into the upper skin pocket. And see, there is no initial great definition, but as you just follow up the patient, this is how the definition comes. So our pressure to generate immediate definition, the immediate framework reconstruction and position of the framework should be brilliant. That if there is any compromise in that, you will never achieve good outcome. But if these parameters are taken care of, finally it does drape. And this is our patient. So second stage in Nagata's technique, basically it's the same for both the Furman's technique, what Dr. Parag is demonstrating. You take the split thickness skin graft from scalp for better color match and use TPF. The best part is that, and the dangerous part is that you have to expose the helix fully and then cover the helix with TPF. So what I would advise, first raise the TPF, make sure that your fascial flap is well vascular and appropriately raised, then only remove the skin from top of the helix. I'll show you a video about that. And then after elevation, presently, like before his passing away, and since for last 10 years, Dr. Nagata was using normal side 7th costal cartilage for elevation, making a big L-shaped piece for elevation. Initially, he was using bank cartilage, but we still use some bank cartilage because our patients are not very happy with second incision just for harvesting a cartilage. So this is how a zigzag incision is given, and some skin, extra skin is taken, and the fascial flap is raised, and this flap is tunneled on this side, and it covers the whole framework. and behind that you put a cartilage for elevation and then cover it with TPF. And we use, this is a very good way of keeping a splint. We use a Foley's catheter as a ring around the ear because other things just keep falling apart. So you put anything behind, some ways, some people are just using on the spectacles and put something behind. It also becomes cumbersome for many people. Those who are not using spectacles, they are troubled by it. So we just thought of using this Foley's catheter ring, and it stays there, and it works like a good splint which prevents the posterior sulcus contracture. Whatever you do, it just contracts back to some level, even after TPF. So this is this patient long term, and then this is covered with TPF. And this is one patient I told that ear will resorb little bit and over a period of time. But in him, we covered it with TPF within 6 months, and it has not resorbed at all. And it is 8 years down the line, it is looking like this. And every 6 months he calls me that you told the ear will go down. It is only 4 millimeter larger than the other ear, actual dimensions. But it looks big to him, and he is behind my life for this thing. Last 7 years. So that's what happens. But it doesn't resolve if you do cover it with TPF. That is the point. So this is the elevation. It is not very big. We have mentioned, we have measured the dimensions, just 4 or 5 millimeter larger. So in adults, if sometimes it is really ossified and very difficult to do carving, it actually fractures. Yesterday also we were struggling, but it did not fracture somehow. It fractured one point at the base plate, but we could manage. 27-year-old female. But this patient came, and she was also around 29. And now see, in this part of the lobule, we just want this part we cut and just transferred so that she can wear earrings. But still this red dot, we left it attached as a Nagata's technique. It's a very important thing. If this thing remains attached, it will create a conchal depression and keep the skin viable. Otherwise the skin dies at this point, and it creates lot of complications. So keeping this portion attached at the place where you want the cavum concha to be is one of the most important contributions of Dr. Nagata, because otherwise you struggle. So we made a multi-piece framework in her because it was simply not carvable. So each piece was joined together. So suppose if you have a broader cartilage, from that only you can take a contour of the upper part of the helix, just carve it. So there is no tension, and you just take rounded pieces and then join them together. And then we created this multi-piece framework. But she was very happy. She was able to wear her earrings, although it looked, you can see the breaks, but this patient was extremely happy with what could be achieved in our situation. Now, one of the cases we are supposed to do yesterday was a 8-year-old child with microtia, and her chest circumference was only 57.5 centimeter with very flimsy cartilage. So we resisted the temptation and did not do that child, because it would have, now this child we did initially maybe 12 years ago. We carved out some framework, and at that time the technique was also not refined, but the framework was reasonably okay. And then within a short time it just disappeared. 1 year or 2 or 3 months it just got resorbed. Before we could think of elevation, we were thinking it is looking good, but by the time he came back to us it was all gone. So we had to do another, we waited for some time, created another solid framework, and this framework was created, and then we achieved this thing, and he was happy thereafter. So secondary ear reconstruction is another. We have a patient which we are planning, and probably they will travel to us. Now this patient was operated 5 or 6 times with scarring behind the ear and this anteriorly displaced and downward displaced auricle. Uh, expanders were used multiple times. Their framework adjustments were done, but she was in real depression when she came to us. Absolutely like this, not smiling, not doing it. And the skin was very fibrosed and tough. So we are publishing this very soon. We, as a principle, first we have to remove all the scarred tissue and normalize the position of the ear. You have to just pull it back to normal. Remove all the scar. So we did that, and we excised the scar, shifted along with the bad framework, we just shifted everything up. So dissected it out and we just pulled it up in the normal position and elevated position. And then just did the suturing so that the position was normalized. Once this thing was done, we are sure that we didn't want to damage the skin. And then she was okay. Then already the looks changed, but just by whatever was there, it came in normal position. And then after some time, like in few, I would say 20 days or so, we just let it settle, just see that the skin is fine. We remove the deformed framework. At that time we put a small expander just to maintain the space, because they were so paranoid and we were so much worried. This could have been done, this putting of the expander would have been done in the first stage itself, but at that time we just put the expander just to see that the skin remains viable, because there was only one chance. We did not inflate the expander much, just 10-20 cc we put, and just again waited for some more time, maybe another 2 or 3 weeks we waited. And then we put a nice framework, created a nice framework for her, and then removed the expander and put the framework underneath. And you can see there is no definition. The skin is almost 6 millimeter thick skin with capsule. And I told them that please do not come to me for 1 year regarding the definition, but they kept on telling me, no, definition is not coming. Definition is not coming. After 14 months, this is a definition. Now she is totally happy, and she is a YouTube singer, and now she doesn't keep it covered, and all the definition came back. So from there she reached here. So it's just a matter of time. If the framework is good, you will get definition and the patients will be happy. Post-traumatic also, like this gentleman, like this is a single piece carving. So he was 53-year-old, totally ossified cartilage, and whatever portion was missing. Initially the skin was so tight, so we just dissected it out and put a tissue expander just to maintain the space. It is not for expanding as such. People have used expansion also, that's also fine. And we just maintained the space, and then in after few days, after 2 or 3 weeks, we just put a good framework. Somehow I just missing that photo of the partial framework. And then we elevated. I'll show you the video of the elevation, and then after elevation with the TPF, it's all bone piece actually. It's a bone piece which we banged and put it behind. And then this is how initially it looks. And we used this, our Foley's catheter ring for him. And this is how it is now. He is happy. He needs some little adjustment to pull it behind, but his definition has come back. And it's a single piece framework. There is no added helix or anti-helix in this. We just used a burr, diamond burr, kept it in a kidney tray and then carved out this here and then just put it there. So this is how it is. It needs some pulling back actually. Some very difficult cases in which only the lower part of the ear has to be made with lot of scarring. So we use initial expanders, then identify the position of the ear, and then create only the lower portion of the ear, which is missing, but it doesn't reflect well if it is a totally scarred skin. And we just put this thing behind and then sutured the normal cartilage to the framework cartilage. Finally, he is looking like this. He is happy from what he was before, but obviously the result is compromised because of the extreme scarring in the lower portion. Probably in this particular situation, when we think, the another option could be you really raise the temporoparietal fascial flap and dissect it up till here onto the vessels, and then use this thing to cover the framework. That's another option. And another case of post-traumatic ear reconstruction, you just keep matching what is missing and just create exactly the missing portion and then put it into the pocket. In this case, the skin was supple, so we joined this reconstructed cartilage framework to the native cartilage with PDA sutures. And initially it looks like this, and later on this kind of definition comes, and then patients are happy. So the hairline idealization, you can give the laser preoperatively, hair removal laser. And even after framework creation, you can use laser to remove the existing hair, and they are satisfied with that. And this is Dr. Nagata's very innovative technique of correcting the lower hairline, in which you just identify the correct position of the framework and you just lift off this skin as a full thickness skin graft or a thick split thickness skin graft, and all the hair follicles in this region you excise, put the framework, put the TPF on top, and then replace this back as a graft. This takes care of the hairline problem. So this we have published our article also last year on whatever understanding we have. Thank you very much. Yes. We have time. I can quickly show you ear elevation. Yes, sir.
Please, sir.
Can we run it at 2x or something? Is it नहीं होगा ना? Can we run it faster? Because it's 24 minutes. VLC से ही खोला है. Playback speed. हाँ, you can no, two times. ठीक है. So we are that's okay. Yes. So we are raising the TPF. Yesterday we struggled because the burned skin was very thin and everything was inflamed. But you just use lot of tumescent solution. First mark the temporoparietal temporal vessels, so that you are very careful while you are on top of those vessels. Use just elevate it just below the hair follicles. But still, whatever care you take, always there is some alopecia which happens with this technique. So you have to counsel patient accordingly. But if you can maintain a good plane, so always our rule is first raise the TPF, then think about elevation. Because if you elevate it and you remove the skin from top of the helix, then your framework is gone. So first make sure that your flap is fine. And as I was telling yesterday, there could be a distance between artery and vein. So you have to give equal importance to the vein also. If only artery is there, the flap may not work. So you have to have a draining vein nicely preserved. Its pain is taking, but it is fairly okay. So you just mark it and you raise it just above the deep temporal fascia, which is the covering of the temporalis muscle. Try to make field bloodless as much as possible. Now, as mentioned, this deep temporal fascia also it has a different blood supply, and it can be used. It also can be used for cover. Although even I have not used it till now, but it can be used. So very carefully preserve the vein as well as the artery. And then around, at least take 1 to 1.5 centimeter around the framework so the skin can drape back, because it becomes thicker after you put the TPF. Things are edematous. And this is the incision for the and now we raise a very thin skin, leaving all the hair follicles behind. And it exposes the hallux also. And then you excise all the hair follicles. So up till the scaphoid fossa we go, and then fill or just attach the flap into the scaphoid fossa, which is covering the hallux with the 50 PDS. So flap you take in the maximum dimension and maximum length. This is just the banked cartilage harvest. So this cartilage piece, it comes behind the antihelix, and we can fix it with 3O PDS. There are various ways of doing it. As Dr. Parag was mentioning, it can be tunneled behind the framework, and you can keep some subcutaneous tissue and then just put it in between the framework and some tissue which is there, but it doesn't make much difference if you have a very vascularized flap for covering. So we And while taking the stitches in this TPF, you have to just make sure that you don't inadvertently catch the artery or the vein. So the whole of helix is covered nicely with this flap. So I'm taking from the scaphoid fossa and then catching this TPF and then fixing it there. Initially it looks bulky because of the edema, but later on everything settles nicely. So till the lowermost portion we have covered the framework. And then you have to mobilize the posterior scalp skin and bring it as near the posterior aspect of the auricle as possible, so that the grafted area doesn't become visible. It should be behind the posterior surface of the auricle. So you just pull it up. You take 2-0 vicryl and then just pull this skin up like this. So it gives a good semblance of elevation. And a dog ear happens after that, which you correct. When you join these things together, there is a dog ear, and which you just correct it. And while fixing the TPF, you fix it as much behind as possible so that the sulcus is created. And after that, very gently you stitch the skin on top of TPF. So you pull it as much as it is possible. And then you take a skin graft from the scalp and very gently attach it and put a gentle tie over. No pressure, no too much of pressure. You can take with the Watson's or Humvee's knife, and then by rubbing this gauze piece on top of that, you can remove all the hair. So this is how it comes, and then you just attach the skin graft and put a gentle tie over. So that is the technique of elevation. Do we have 7 or 8 minutes of time? Or we are done. This last thing, if you permit, otherwise. Huh? 5 मिनट हाँ उनको बोलने दो मैं खड़ा हूँ.
Parag sir, are we audible sir? Hello, Parag sir?
Yes, please. Can you unmute me?
Sir, are we audible, Parag sir?
Yeah, am I audible to you?
No sir, the voice is very faint.
Am I on mute? Am I audible now?
We can't hear you, sir.
You can't hear me? Am I audible now?
Yes, sir. You're audible, sir.
Okay. So we have applied suction drains to the reconstructed part, and the contours are quite okay. The uppermost part, you can see there are few hair follicles, but as Mohit sir said, when you elevate it, you just have to take an incision, lift up the skin and remove all this tissue with the hair roots, and then put the skin back. So all these hair will be gone. Now I just gently pack with Bactigrass, with Tulgra, one in the concha, and then you put some ointment. Next. One in the scapha. थोड़ा और लेंगे ये and the small piece cut करो in the triangular course. So that's it. After this I'll just do a master dressing so we can go back to Mohit sir's video.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you. Very nice.
Thank you, sir. Thank you very much. Ointment थोड़ा अजून कट मोठे.
So this is a microtia patient. So again, this red dot is the part of the skin which remains attached, and the lobule splitting incision. Always it is a good practice to mark the superficial temporal vessels. This is quite an old video in which at that time we were still using stainless steel wires. So we create the pocket but maintain the attachment. So this attachment here is maintained, and then see, this is external oblique, this is rectus. You split these muscles and you take 6, 7, 8, 9 costal cartilages, which is fairly easy in children. There is not much struggle, it comes off easily. So this 7, in this child, the width was not much, so we had to use actually 3 pieces for the framework in this child. You just shaping it like this so that there is no sharp contour in this thing. You just and then join 6 to 7. Still you see, after joining 6 to 7, there is some more part of the template which is remaining, so we use another piece for that. It doesn't matter because base plate has to be of appropriate size. This is a foundation on which you build the platform, this whole thing. So in this child also we faced some extrusions. So that's why thereafter we drifted away from stainless steel wires because it was causing us persistent problems. So this is not the this is not the part of base plate. Base plate comes only up till here. There were some variations in this framework, but more or less the principles have to be understood. It should not be made too thin because cartilage becomes weak. So you just have to deepen it slightly because you are adding additional pieces on top. So this gouge will cut up till the depth where you have given incision with the 15 number blade. So this is a technique. If you cut with a 15 number blade up till 2 millimeters, this gouge will take that 2 millimeter thing very easily. So that's one should remember. So this we are creating the anti-helix with a 9th coastal cartilage. So it should not come till the very end. There should be some gap here, otherwise the skin doesn't drape. And you see, we try to bury the stainless steel wires under the cartilage, but even then it resorbs. All the frameworks resorb. So you have to, in a timely fashion, cover it with some vascularized tissue. That's why you don't see any long-term outcomes by anybody, because everything resorbs. So don't get disappointed. Means it has to be. If you just follow up your cases long-term, then you realize that there has to be some logic behind covering it. So this we are just cutting like this. This is a 8 coastal cartilage. And then you would have seen yesterday, we just took with a gouge the inside of the 8 coastal cartilage, we just created a concavity and then we fix it at this point. And we create a wedge into the helical rim so that it just sits on top nicely, and then we fix it. Here also the 8 coastal cartilage was also not very strong, so we had to use more pieces. It was unusual. Normally we don't need a piece at this point, but if you join it very properly, it doesn't make any difference. It's not actually visible from. Ideally the 8 coastal cartilage comes up till the mid portion of the ear at least, but in this we had to use 3 pieces, and even then we had. So this is a tragal creation. And you create some concavity on the under surface so that the skin can contour. on the side of the tragus. So this side is concave. And first you fix it and then you trim this thing off. It should not be of too much of height also, because the lobule will come on top of it, the split lobule, and it will get compromised. So you just put this thing like this with a good intertragal notch. You just keep checking the dimension. And here the antitragus was also weak, so we added another piece. It is not required. It is just in this particular child we added. I think this is only once I have done like this. So don't take it as a part of the framework creation. And this is the third layer. This is the conchal piece. This you could observe yesterday as well also. This is fixed behind the anti-helix. So now you see all the components. There is good gap here, and this is the conchal piece. So it's a three-dimensional framework. And then it goes in. So just this is the subcutaneous attachment here, and then it goes around like this. Yeah, so whatever excess skin is there, you just nicely trim and apply suction cannulas. So this is how it looks once it settles. So that completes whatever I had to show to you. Any questions you have?
Sir, there is one question in the chat box, sir. They are asking for the TPF harvest, sir. Why can't we use a lazy S incision instead of the zigzag incision, sir?
You can use anything, no problems. Basically, zigzag we are giving because every time it gives alopecia, and if it is total zigzag, then it is hidden. Not in my situation, but other situation.
Sir, one question. Sir, in the presentation, you have seen three marks we have seen, sir. One outer marking, then there were dot marking, then there was a final inner solid marking. So, so inner marking we could understand it up to the framework where actually it is going to lie.
Should I take it out, that marking?
No, sir. I want to know the significance of this second marking.
No, to understand what you are.
Yes, sir. Please.
That's what I am saying.
In the elevation video
This?
also.
Regarding elevation?
Yes, in the elevation video.
Oh, elevation video?
Yes, sir.
Sorry. Yeah.
The video, no, sir, the video is just finished. The child was in that in the last video, sir.
The last what I just finished.
Yes, sir. In that video, there were 3 markings.
Elevation video. That is just a framework.
Okay, framework. Yes, sir. Yes. So there are 3 markings, 2 solid and 1 dot by dot.
Yeah, this is the superficial temporal vessel.
Blue marking, sir. Blue. So,
It's just like that.
so no significance of that marking in dot, blue dot.
I don't know. This is basically up till here we have to decide.
Okay, sir.
Okay.
Yes, sir.
And this is just for style. Nothing else. This is just
So-
not the template. I cannot tell you, but you just put a template marking.
Yes, sir.
And beyond that 2 centimeter you do the section.
2 centimeter this is the marking.
2 centimeter.
Yes. And sir, second question is regarding that red dot where tissue is to be kept in continuity. So what should be the width? How do we know that this much is to be kept? 1 centimeter.
Make 1 centimeter diameter round like that. You see this cavum concha?
Yes, sir.
Around 1 centimeter or something, you just leave it attached. Even 7-8 millimeter, you leave it attached.
Okay.
That will keep the skin vascularized at that point.
And sir, as you were discussing yesterday, sir, there is one perforator which is coming from the posterior auricular artery to the skin. Sir, do we need to preserve it always, or is this point corresponding to that perforator artery?
Nothing. You just make sure that your framework is well positioned, and wherever the framework is coming, in that template, where the conchal region is there, this should remain depressed. There you keep this thing intact. You go around it. So we are incising here, in this green line. We are splitting the lobule also, so we are incising here. So you do your dissection, all the dissection from the top, and from here also you do your dissection, and then go around, but maintain the connection. It may be even 5-6 millimeter of attachment will do. It will keep it vascular.
And sir, regarding the width of the scapha, sir, how much should be the minimum width of the scapha for skin to drape?
What Parag was telling.
Yes, sir, because in the last presentation which we saw, the minimum width was not appear to be, it did not appear to be 3 to 4 millimeter or 4 to 5 millimeter.
Viscerally drape.
Yes.
So what happens is, if your framework is okay, your skin is alive, and your position is fine, body pulls everything inside with the force you cannot imagine. It fractures the cartilage on. 6 months, 1 year down the line, it will keep on pulling skin inside. So wherever there is a depression, the skin will go in. So don't worry about it. You just make a good framework. At least there should be some gap, but the skin will be pulled inside. Don't make it too narrow. You try to keep at least 3-4 millimeter if it is there. Little bit of cartilage keeps on tilting. So what happens, even in the framework, if it is not appearing, while inserting the framework, you can just put it in. Can we just drape it? I'm not saying that skin, one should not never try to drape the skin, but if your framework is solid and your skin is not coming totally inside, don't worry. Just leave it like this. It will come. Guarantee.
The third piece, is it necessary? Can we put it all times, because sometimes the skin may not yield to adjust the whole of framework.
Then you make a smaller circle. You just see, you keep it smaller, but keep it because it gives a better definition.
So even after doing this in the first stage, we need to put on additional cartilage for elevation.
Yes, because even after putting that additional cartilage, then also it contracts. It is pulled back with the force of contraction.
So how much access should we keep then for?
How much access?
So because it is getting contracted, so definitely it will pull back. So counter that, we need to put a sturdy.
But it should be sturdy, and at the same time you should
use your ring splint or some sort of splint, if something comes in between here, it arrests the forces of contraction.
So for how long should we use that police catheter splint?
At least 6 to 9 months.
Okay.
Yeah, yeah, yeah.
Thank you, Professor Mohit, for showing your amazing results.
Thank you.
Would have been
Thank you, sir.
taken a lot more time because due to other surgeons are also there, sir. So the time constraint, we beg apology from you.
Thank you.
And so we wanted to see some more complication. I think you have not shown, sir. If at all something has
Yeah.
occurred,
There are so many complications that you will
get depressed by seeing disheartened.
Yeah, don't want to dishearten you.
Okay, thank you, sir.
More complications than success.
Thank you, sir.
OT1, are we audible? Bhandari sir?
वो उनको
Sir, Bhandari sir? OT1?
ओके जस्ट डू दैट यार आपका ना नीडल बहुत छोटा है, वो देना मुझे आर्टरी फॉरसेप्स
Vidush, wait for a second.
उसमें क्या करते हैं सिस्टर लॉन्गर नीडल कोई मंगवा लो यू विल डू इट लाइक दिस इट बिकम्स हेलो यार ये तुम्हारा नीडल अच्छा नहीं ना यार
Vidush, are we
Yes, sir.
audible?
We hear you, sir.
बड़ा नीडल कोई आया है
Surya, 5 minutes.
Yeah, sure.
We are felicitating.
What is they saying?
5 minutes.
They've gone for the lunch, I believe. है ना कोई बात है. You're getting my point. Why I'm doing like this? The knot has gone in. So sometime if the helical margin is very small, like if this eighth rib is very small, so I'll do this only to make the, this can also make the helical margin.
Sorry to interrupt. We would like to invite Dr. Mohit Sharma sir onto the stage. Sir, please.
I was not able to come yesterday evening as I was there. We are not able to participate. So I'm thankful to Mohit sir because it was not easy to catch him. But anyway, sir has given enough time. 3 days is not is so hectic schedule, but still then sir has given 3 days. Sir, on core of my head, I am thankful to you sir for giving 3 days. Tomorrow is sir also there for carving. So small bit of a felicitation.
Shika ma'am.
Because in a very short notice
artist madam has agreed to come to assist and sir, Mandari sir.
Yeah.
Sir. Sir, are you able to hear? Hello.
I only wish that the temporoparator flap survives. It will survive. Your heart says or your...
Sir, please tell about the carving part of the cartilage, sir. Because we are just completed the presentation of Mohit sir.
Yeah, can you see this? So we have given some mammary incision. Are you with us?
Yes, sir. Yes.
So it was a long incision, and there was a deformity on the right side. We have taken it from the left side. Suddenly I realize I'm not making wrong. It is the same side. So we have taken the cartilage from the same side, and the 8th rib was lying very, very far inferiorly. So we have taken a little more cartilage from the 6th and 7th. The helical margin forceps, which you are seeing, is a portion of the 7th cartilage. Can you see this?
Yes, sir.
So it was a broad cartilage. We have carved out the basal framework, and we had enough strip which could be made for the helical rim. So this is made out of 7th costal cartilage. Can you see this here?
Yes, sir.
And it looks fine. So it can sometime, if it is not there or if it is very small, then it can be done like this also. Then the other thing I wanted to tell you, can you see this? I am taking curved needle going between the helical margin and basal framework. Is it visible to you?
Yes, sir. So you are using Prolene or polyamide, sir? This is?
So I have started taking the sutures between the helical margin and the basal framework. Can you see this here?
Yes, sir. So that is Prolene, sir.
That is 4O Prolene round body.
Okay, sir.
So see, basically I wanted to tell you, see, it has to be curved. Now it has gone through the helical margin. Then it is going through the basal framework. Hold this. It is going through the basal framework. It has gone. This cartilage is also ossified. In between there is calcification. So sometimes I am finding it difficult to carve out and put through the suture. Now suture ultimately is coming between the cartilage, helical margin and the basal framework. I hope you are able to understand this.
Yes, sir.
So the knot would be lying. Can you see this?
Yes, sir. Very much, sir.
इसको मिलाने से. So when I am tying the knot, it is buried between the helical margin and the basal framework. Can you see this?
Yes,
knot
sir.
has
Yes,
gone
sir.
in.
Yeah.
See, the knot has gone in. So knot is not visible from any surface, because if it is lying on the posterior surface, once you raise it, then it becomes superficial.
And the chances of extrusion will
So,
be there, sir.
so can you see the knot is buried inside? I hope you understand.
Yes, sir. Yes, sir.
I'll show you again another one. Hold this. So I'm starting at the junction between the two. Oh, So it's gone up, starting between the two, between the basal framework and the helical margin. Then again going from the superior margins of the helix. So it is ossified here, so it's finding it difficult to pass through the needle. So we have taken through the helical margin. Now I'm going through the basal framework. Not going. It is all ossified. Cartilage is ossified. Difficult to even pierce it from this side.
Sir, in such cases, can we take drill? Can you go drill the drill bits, sir? Some 1 mm or so, 1.2 mm drill holes. Can you make holes with drill? There is no need, sir. When it is ossified, sir, in bony ribs or the costochondral cartilage when gets ossified, do you ever use something like that, sir? Making holes and no, or you always manage with this method only? Professor Bhandari sir, we are all eager to hear from you, sir. Hello.
Hello, Satya. Hello, audible. Hello. Clear हो गया. Hello. Hello. Hello.
Hello. Hello.
हेलो आवाज़ आ रही है हेलो
Hello. Yeah. Can you hear me?
हाँ क्या क्या
क्या status है?
क्या क्वेश्चन
So everybody has gone for lunch break right now. Just give us 5 minutes and we'll get back to you.
ओके ओके
Hello, Priyanka.
हाँ हेलो
हाँ Priyanka, there is a question in chat box. Everybody is asking where sir has brought this silicon platform from. It looks quite nice for the carving purpose.
दे आर आस्किंग
Silicon platform.
हाँ where did sir get this are they asking that
Yes.
okay okay
Is it like from a normal stationery shop or is it like available with some this pharmaceutical
Mayo
vendors?
yeah ये it is manufactured by Myovitech
Myovat.
It is marketed by Myovitech. Marketed by Myovitech company. I'll give you the number. You can
All
directly
right.
ask them to supply it.
Yes, sir. Thank you so much, sir. Hello? Priyanka? Hello, am I audible in OT1? Hello?
Hello?
Hello? Priyanka? Anisha? Am I audible in OT1? Has everybody taken lunch? Just lunch is done. Sir, lunch is.
Hello, are we audible in the auditorium? This is the
Hello, Anisha, can you hear me?
I can hear you, ma'am. Can you hear me?
Yes, you are loud and clear. So I'll hand over the mic to Parag sir, and please tell us what is happening in the OT right now.
Yes, ma'am.
Hello.
Good afternoon, sir. Can you hear me?
Yeah, I can.
Very nice framework, sir.
Thank you. Actually, if there is a deformity in the chest wall.
Right, sir.
So the cartilage was lying very low, and I have given a submammary incision.
Right,
so
sir.
this helical rim was made from this 7th cartilage itself. It was a broad cartilage,
Correct.
chondrosals.
Correct.
So we could carve out the basal framework, leaving a margin which could be used for the helical margin.
Right, sir.
So sometime if you find like this, so it can be used for the helical reconstruction. So that is what has been done here.
Right. Yesterday we saw Mohit sir do it the Nagata way, where the root of the helical rim was joined to the base frame. Do you sometimes do that, sir?
Hello.
Hello. Hello.
Hello.
Sir, can we repeat the question?
So yesterday we saw Mohit sir do the root of the helical rim in a different way, where the root of the helical rim was joined to the base frame. I wanted to ask Bandari sir if he fixes it that way sometimes.
I will not actually attach it with the help of a suture. I'll just bend it. Will not go right up to the basal framework, but little bend it. I understand.
Thank you, sir.
I'll bring it closer to that. I do a mixture of the Brent, Nagata and Farmin. So this is what the Brent does. Not going right up to there, just bending a little bit. अच्छा ग्राफ लेना बच्चे हाँ अच्छा ग्राफ लेना होता है Anti-helical Martian will continue to form gas. Can you see this? Should be the same level. It should be at the same level.
Bandari sir, can you hear me?
OT1, hello.
Can you hear me, sir?
Bhandari sir?
Hello? Hello, am I audible?
Yeah, you are audible.
Sir?
Hello?
Yes, sir. Excellent demonstration. It's looking very nice.
Where is the camera like? Over here? What Dr. Mohit was saying, the anti-helical margin has to be at the lower level as compared to the helical margin. But in the middle third, it can be little higher because normally also in the middle third, anti-helix is little higher as compared to the helical margin. But the rest of the portion has to be low. So it is little high over here, so I wanted to reduce with the scraping. That is what I was doing. Yeah, this portion.
Can you show it to us in the profile view, sir, so we can see the thickness of the framework?
Like this?
Yes, sir. From the other side, from the concal side.
Actually, voice is not very clear. I don't know why it is echoing over here. Voice is not very clear. And I am not putting a cartilage over here because the concal cartilage which is already there, I'll put it over that. So that will act as elevating the cartilage. I'll show you over there. Can you hear us?
Yes, sir, you are audible now.
Forceps. So, can you see this concal cartilage?
Yes, sir.
So I am going to fix it with this. So it is giving the elevation.
That's correct.
And it will be like this. I have to dissect it out over here. This is the tragus portion. So, and it will be like covering this area. And this is the sulcus over here. Can you see the sulcus?
Right, sir.
Yeah. So that is what is going to be. So everything is done now. I am just going to dissect this portion and then put the cartilage and wrap it with the fascia. Right? I think I'll have a break for 10 minutes and come back again.
Sure, sir. Very well done.
Next, Dr. Parag Telang sir. And I would like to request Dr. Prithviraj sir to be the chairperson for this talk. So,
Good afternoon, everyone. So this talk is going to focus on the other aspect where you need to reconstruct, which is the post-traumatic case. So how does a post-traumatic defect differ from microtia is in the local condition of the skin. In microtia you have a skin which is very thin, which is pliable, and which you can stretch out by giving more projection to your framework. In trauma, that's not the case. In trauma, most of the times the skin is going to be very scarred, and the pliability may not be as good as what you want it to be. So the approach to post-traumatic ear defects has to be slightly modified. The first thing that you need to decide when you have a patient of post-traumatic ear defect is whether you are going to use something for support. Now, until your defect is so small, like half a centimeter or 1 centimeter, where you may not need any support, majority of the cases you do need support. This support can be in two forms. Either you can use conchal cartilage or costal cartilage. Now, a conchal cartilage, though it avoids a chest incision, it does have its share of drawbacks. One, you can't really replicate contours of the ear. Since the past 1.5 days, you have been seeing 3 different people carving the framework of the ear, and I think by now it must be quite clear that you really need good contours in order to replicate the shape of the ear. Plus, the conchal cartilage is limited in terms of the size. You are not going to get something more than 3 centimeter. Other problem with the conchal cartilage, it is not resilient enough. It is so thin that it may not be able to withstand the contractile forces, and therefore conchal cartilage is not always the preferred modality. The thing with costal cartilage is that most of the defects, if you learn to analyze a defect in 3D, it is not only a 2-dimensional defect, so it is not only the length and the breadth, you also have to think of it in terms of the depth. So when you have a defect, it is usually in more than one plane. You need to replicate the complex contours of whatever has been damaged. So you need a cartilage which is resilient, and you need a cartilage which is able to withstand the contractile forces of the skin envelope. So in partial ear reconstruction, I follow this subunit principle of dividing the ear into 3 portions: upper 1/3, middle 1/3, and lower 1/3. Now the reconstruction for each of these subunits is slightly different. So you can apply this to post-traumatic defects, to defects which are surgically created, defects which are sometimes caused by a badly performed otoplasty, and sometimes post-infective deformations of the cartilage such as a cauliflower ear. Of course, in order to use costal cartilage directly under the skin, you need a good skin cover. If not, then STPF is what will be required. You shouldn't have any active local infection. If you have infection, treat the infection first. Don't be in a hurry to reconstruct the ear, because the infection will just eat on and destroy the cartilage. It's always a challenge when you have an elderly patient and you have rib cartilages which are badly ossified. So getting non-ossified cartilages is a prerequisite, and you always need to train in harvesting a STPF, that is your lifeboat, if the local skin is not available. For this kind of an upper third defect, so upper third means if you draw a horizontal line from the base of the helical root like this, what you need to reconstruct is a portion of the helical rim, a portion of the Y of the antihelix, and of course the most projected part of the ear, we learned that this is the highest projection on the antihelix, and somewhere here is the highest projection on the helical rim. So you need to create a piece which is going to replicate that projection. So let us look at one case example where there was a defect post otoplasty. This is Dr. Parmin's case, and she has reconstructed it using costal cartilage. This patient came to her following an otoplasty done elsewhere. So as I said, there are two principles that you need to use while deciding whether you can use conchal or costal. One, if it is involving more than 1/3 of the length of the ear, and two, if it is involving more than two planes. So if you look at this defect, it is not only a vertical and horizontal defect, it's also a defect of the depth. What has happened is, because the otoplasty sutures have destroyed the antihelix, the depth of the concha is lost. So if you have a defect which is more than 1/3 the size of the ear, or if you have a defect which is involving more than two planes, you need to use costal cartilage. So in this particular case, she has used a direct skin approach, and the missing part of the ear was the Y of the antihelix. You see how badly damaged the native cartilage is. So you just remove the damaged portion of the native cartilage, insert the new cartilage graft, and then stitch it back, and that usually should be the end of it. So this is how you can reconstruct upper 1/3 defects. Now sometimes the upper 1/3 involves the helical rim. When the upper 1/3 defect involves the helical rim, then of course you need to have projection. So how you saw in the morning that we had two stacked cartilages, one for the base frame and one for the helical rim, like that sometimes you need to stack a small piece of cartilage on the base frame to give this extra projection to the helical rim. And of course, if you see, the defect is not only involving the helical rim, the scapha is also lost. So when you make a imprint of the opposite ear, you will find that the actual piece required is a helical rim plus the scapha, which has what been created. I have not created the inferior crux of the Y of the antihelix, just the upper or a superior crus, and that has been joined to the Y of the antihelix. But because there are two cartilages, one stacked on top of the other, you can create a little bit of depth so that the helical rim can look appropriate. And then of course you can elevate it after 6 months, like how you normally would elevate in case of microtia with a split thickness skin graft and cartilage. So even when you have the opposite ear which is quite prominent, it is not really a normal ear, it's a prominent ear, you can still create the same kind of projection by the proper use of cartilage support and a skin graft. So these are defects of the upper third. Let us look at one more scenario where the patient had some kind of an infection, and when I opened the skin, I found that the cartilage was totally deformed. And it's all about the support with cartilage. You cannot expect this to give a normal looking ear because there is no support inside. So we had to make the missing piece of cartilage and insert it in the correct location, and that's how you can recreate the Y and the helical rim. Of course, this patient was from out of India, so I don't have his late post-op. Now when we talk of defects of the middle 1/3 means it's an area which will involve the deepest part of the conchal bole and also the most projected part of the antihelix. So we need to create the depth of the conchal bole and also the missing part of the antihelix. This also is a case mentioned by Dr. Parmin in her book, and you can see that this also is a complication of otoplasty. The skin has completely collapsed because the underlying cartilage has collapsed, and when you actually make a tracing of the normal ear, you find that it is not only the helical rim which is missing, it is also the lower part of this scapha extension, the concavity, and plus the Y of the antihelix which is missing. So this has been carved out of a single piece of cartilage, direct incision on the anterior aspect somewhere here, and insertion of the new costal cartilage block to recreate the shape of the ear. Again, one single stage, because the skin is quite normal. The skin is not scarred, the skin is not contracted. Another case of mine where the patient had a traumatic amputation. It is actually something which is a little more than the middle third. It is involving a part of the upper third as well and a little bit of lobule as well. So when you actually see what is the missing fragment, it is a little bit of the helical rim, most of the lower part of the ear, a little bit in the lobule, and the upper limb of the Y of the antihelix. So again, a direct incision, you deglove the pocket of the skin around and you create a space for your new framework, and then you insert this framework and join it to the native cartilage so that you don't see any contour irregularities, and then you of course put a suction drain so that the skin coapts properly with the framework. That brings me to the lower one third. Now lower one third comprises of the lobule, the tragus and the antitragus. Now lobule normally does not have cartilage, but sometimes you need to add a little bit of cartilage extending on into the lobule, because that gives stiffness to the lobule. Otherwise the lobule keeps on moving like this, and that's not what patients really like. Again, costal cartilage may sometimes be used to replicate complex contours. You can, for smaller defects, use a conchal cartilage as well, but this was a defect due to trauma, and the patient's other ear was quite large. His other lobule was somewhere here, so I used a small piece of conchal costal cartilage to recreate the missing part. So in this also, the concavity of the scapha has been done in this recreated part as well, which you can see once the suction is applied, because this has also been lost. So it's not only a lobular defect, it's a little more than the lobule, and this is how you can reconstruct lower one third defects. Another case where the patient had some kind of a benign tumor which had to be excised. So the upper one third of the ear was left intact and the lower two thirds was missing. This was the missing part of the framework. So when you make a tracing of the normal ear, you realize what has been lost, and then this is the suture line and the missing part of the framework which has been attached. After 6 months, you can of course elevate it and create the post-auricular sulcus. So these are defects of the lower part, or lower one third of the ear. Now the defect sometimes does not conform to any subunit principle, and you have cases of avulsion, you have cases of burns or amputations which may involve almost the entire pinna. But in most of these cases you still find that the tragus is spared and the local skin may be damaged, so STPF may be one of the options that is required. A patient of a road traffic accident with complete amputation of the pinna, his tragus has been preserved though. So the markings what you saw in the morning and yesterday as well. So you mark the size of the opposite ear, the axis of the ear that you want to make. Then you of course carve out the cartilage that you want to insert. So this is the framework, a double layer framework with a base frame and the helical rim and the Y of the antihelix created. And when it's inserted, this is after the first stage where the framework has been inserted in the correct location, and this is after the elevation. So after elevation you get the proper projection which you can see in this view. So in complete amputations of the ear, you don't have to worry about the ear canal, that is preserved, the tragus is preserved. What you need to reconstruct is a type 2 Firmin framework. Another case with trauma to the upper two thirds of the ear, the lobule was preserved. Again you decide what incision you are going to use, mark the axis of the ear, then you carve the appropriate framework, and then this is after the first stage and this is after the second stage. So you can see that the elevation is easily created by the use of a small costal cartilage graft inserted in the post-auricular sulcus, and this is after the release of the framework. So before concluding, I would like to re-emphasize why costal cartilage is very important sometimes. Was a young child, 5.5, 6-year-old, who came to me with a helical rim defect. So when I opened the skin, I found that the native cartilage was, collapsed. It was like a constricted ear. So as mentioned in textbooks, I unfurled this cartilage by taking some slit incisions, opening it up, and I put this small piece of conchal cartilage from the opposite ear to support this opened up cartilage. Quite reasonable on table. I took some bolster stitches inside and fixed it. It was quite okay by the end of the 3rd month period. But see, 6 months later what happened? 6 months later the conchal cartilage which had been used migrated. This is the conchal cartilage, and again the helical rim is looking like how it was before. So costal cartilage is very, very important. It will give you the ability to add very minute details to your framework. Like this particular gentleman had some trauma to the helical rim. If you look at this photo, you can't even make out that there is a difference in or there is any defect in his ear. But when we compared it with his opposite ear, there was a defect. This had shrunk, the space between the helical rim and the antihelix. So this had migrated inwards, so the width here was less. So actual defect was not only the helical rim, it involved a part of this concavity as well. So when I opened the ear with an anterior approach, I could insert a piece of costal cartilage which allowed me to create both these things, the missing part of the helical rim and the concave part of the extended area of the scapha, and this is how it looks after insertion of this piece. So these kind of minor details you won't be able to recreate unless you use that kind of cartilage. So to conclude, costal cartilage is a very good source of pliable and resilient material. It is very easy to contour costal cartilage. The other advantage is it has very low incidence of infection. It's available in abundance and can be inserted directly under the post-auricular skin. Of course, the disadvantages are that it is relatively stiff, so it's not going to be as elastic as the native cartilage, so you need to tell the patient that they can't keep playing with their ear. It may have a little bit of donor site morbidity for a week or so. The patient does feel discomfort on lying down and getting up from the bed, and it does have its own learning curve. Thank you.
Thank you, sir. To a very difficult problem of pinna defect, you have made it very lucid solution, and always it's a lot of convolutions are there, different plane of reconstruction is required. It's not that easy is of, and but you have shown us very amazing results and you have shared your experience. Thank you, sir.
Thank you. Thank you so much. Any other questions related to any of the defects that you saw, or any other so we'll go back to the OT. Yeah. The resorption rate, it should now normally be 0% if you don't have an infection, and if you have an infection you should treat it on an urgent basis. If you can avoid infection, then there is usually no resorption. Of course, my longest follow-up is of around 13 years, so I don't know how it is going to be after 25 years, but from what I have seen, the cartilage doesn't resorb unless there are some basic mistakes made, like too less under dissected pocket which is giving too much pressure on your cartilage, or some kind of subclinical infection, some suture material getting infected, or stainless steel wire getting infected. If everything is nice and healthy and clean, there is no resorption, nothing happens. Sure. Yeah, if you have a patient who has an intact ear canal, always you should clean it properly with an antibiotic impregnated earbud, and you can give antibiotic ear drops to the patient pre-surgery. The worst infection that one can have is Pseudomonas, so you need to be very, very careful of cleaning the local area properly and emphasize to the patient that they have to wash their ear very, very rigorously every day. It is very difficult sometimes to make patients understand that washing the ear doesn't create problems. Not washing it is what will create problems. So yeah, it's a very important thing to prevent infection, because it is going to be introduced from the local area. Local area therefore has to be cleaned properly. And for female patients, I ask them to wear hair clips so that the hair don't touch the reconstructed part of the ear. Keep the hair tied and away, and that should help. Till the initial healing, I would say 2 weeks. Once the suture line is healed, then then nothing can enter into the pocket. The initial part is important. Thank you. Thank you once again.
Thank you, sir.
Small videos of cartilage carving, if you have some time. You already seen it twice before, and you are already postprandial, so I don't know how much of you will be able to see the carving, but let's try. So So this is sorry. Yeah. So this is not meaning this starts after. Can you mute this? This is not a video where I am harvesting the cartilage. The cartilage has already been harvested, and that's when the actual carving starts. So when you see the base frame, it is usually the synchondrosis between the 6th and the 7th costal cartilages. So as I showed you, you have to lower 2 points. One is the base of the lobule, and the second is the base or root of the helical rim. So these 2 points have to be lowered so that they reach the ground level. So you reduce the excess cartilage in these 2 areas. Then you see where the helical rim is going to be created, and in order to create the helical rim, you need to mark the inner border of the helical rim. So you mark the inner border of the helical rim. Then you mark the posterior border of the antihelix. So the area between the posterior border of the antihelix and your helical rim will have to be made concave in order to replicate the natural concavity. So it's a good idea to use gouges to sculpt this concavity. You really can't have a concave smooth area by using just surgical blades. So you create this concavity by the use of gouges. I have 3 sizes which I showed you, and you can use a medium gouge to begin with, a smaller gouge to create the deepest or the thinnest part rather, and the larger gouge then for the upper part. Someone asked yesterday why you can't make it full thickness, this concavity. Well, you don't really want wobbly parts in the framework. The thinner you make this, the more wobbly the junction between the 7th and the 6th rib is going to be, and then you have to fixate the synchondrosis using sutures. So it doesn't really make sense to remove what God has given in terms of fixation between the 6th and the 7th, and use sutures to recreate the same. So you can thin it up as much as you want, and as you saw in the morning today, after you have thinned it adequately, you can use an 18 gauge needle and create some punctures in the concavity, so that the suction works better in these grooves as well. So that's how the concavity of the scapha and other areas can be created. The next step would then be to create the anti-helix. Now if you look at anyone's ear, the concal area is quite triangular. It is not a semicircle, it is not a C. It is usually like a sharp triangular area, and therefore you need a cartilage piece which is quite pliable. You need a piece which can literally bend on itself, and only then you can create a normal replica of the concha. So you need to excise adequately on the inner aspect, so that you get a framework which is going to mold onto itself. So you see, it's much more than a smooth curve of a C. It's quite like a triangle. Then we create the triangular fossa by removing the excess cartilage in that area. Again, you can either use a 15 number blade, or you can use a gouge to create this triangular fossa. You can also lower the limbs of the superior crus and inferior crus if you feel they are too high. Because we are going to add one more layer of cartilage on top of that, so we don't really want that the Y of the anti-helix should be over projected, so you can lower it slightly. The next piece to be carved is the helical rim. So normally you need a 9.5 to 10 centimeter piece to recreate the entire helical rim. So you decide how much height of the helical rim you want to keep, and because the skin cover is also very important, it is not that you can create a helical rim which is 1 centimeter in height and then your skin will not close. So it is a constant jugglery between projection and safe closure. We don't want a scenario where the cartilage framework was carved very nicely, but then you couldn't cover it properly with the skin cover, and it would cause infection and the resorption of the cartilage. So all your efforts would go down the drain. So you also need to decide how much height of the helical rim you want to create. Then you remove step by step. Don't be in a rush to excise a big chunk of the cartilage. You saw how Mohit sir was carving very patiently yesterday, and you really need to spend some time thinning out the 8th rib to form the helical rim. So you can use either a number 10 blade like what I am using. You can use any other blade that you are comfortable with, and sequentially just go lowering the thickness. Not only on the inner aspect, you can also thin it on the outer aspect. There are some muscle attachments, some fibrous attachments on the outer surface, and you need to run your number 10 surgical blade also on the outer aspect, so that when you look at it from 2/3 profile, the ear doesn't look very thick. If you make a helical rim which is very thick, then when you look at the ear from the side, you can see it like a very thick and heavy ear, which doesn't look natural. So you need to adequately thin the 8th rib, remove these attachments on the outer part of the 8th rib. Now sometimes, as we saw in one of the cases yesterday, if the cartilage is calcified and you are struggling to get a piece of cartilage which can bend like this, you can use your small size gouge and you can create a small groove on the inside of the eighth rib, and that groove also weakens the tensile strength of the cartilage and makes it little easier to mold the cartilage. You can remove the excess soft tissue attachments on the cartilage piece. So keep lowering, keep trimming it till you reach the ideal dimension in terms of what kind of projection you want to create. You should take care not to thin the helical rim too much also, because then when you try to put your sutures through the helical rim, they will just cut through, they will just cheese wire. So the thickness should be around 1.5 to 2 millimeter, so that you get a nice pliable soft piece of cartilage, but it also is resilient enough to allow your sutures to hold. Remove the soft tissue attachments. And you again place the piece on your base frame and see whether it has the adequate length to recreate the helical rim. Sometimes, especially in younger children, you may fall short of adequate length of the helical rim. So instead of being 10 centimeter, you may have a 7 centimeter long rib or a 6.5 centimeter long rib. So you need to use an additional piece of cartilage to lengthen the helical rim. Of course, you need to do it in a way where you really can't see the junction of where it has been joined. Then of course you place this piece on the base frame and you use stainless steel sutures or any other sutures that you are comfortable with to fix these cartilage pieces together. Now when you are fixing these pieces, it's very important that the helical rim sits bang upright on the base frame. You can't have it oblique inwards or outwards. And it's very important to spend adequate time fixing the helical rim till you get a proper projection of the helical rim. So take your time to fix the helical rim properly. Sometimes if the cartilage is ossified or calcified, you may need to use 1 mm drill to make drill holes in the base frame and the helical rim, and then pass your sutures through these drill holes to tie the knots on the posterior aspect. If you are lucky and the cartilage is not calcified, then of course your stainless steel sutures or any other sutures will pass easily. That's why the straight needles are a blessing, because it saves you a lot of time. Then of course, as you saw in the morning, you tie the knots on the under surface of the framework. You shouldn't tighten the knots too much also, but just adequate enough so that the pieces start not moving, they remain stable. Then you cut off the excess lengths of your suture materials and then use a number 15 blade to just turn all the knots inwards and flat on the posterior aspect of the framework. So when you have fixed the helical rim to the base frame, this is how it should remain stable. Because don't forget, when you are going to apply your suction, everything is going to move, and then that's not the time to fix it. This is the time to fix it adequately. Then of course this will be followed by fixation of the piece that you created previously for creating the anti-helix. So you see the length, you see the projection of the anti-helix, see where the highest point of the anti-helix is going to be. Taper down the rest of it, both the crura, taper down the lower part, inferior part of the anti-helix, fix it with the sutures. Again, sometimes the seventh rib or the sixth rib from where we create the Y, it tends to be a little twisted, and you need a good assistant to hold the base frame for you, and then you can stop the cartilage from rotating inwards or outwards, because it has to lie exactly horizontal on the base frame. You can't have it going inward or outward, no obliquities, it has to be horizontal. And keep watching your framework as you fix the different parts. You need to keep checking from each dimension. You see how I'm turning it to right, left, and even in the profile, so that you can see how it is actually going to shape up once all the fixations are done. So again, be sure that the highest point of the anti-helix is at the proper location, and then thin out the rest of it, so that the only part which remains convex is the antitragus. The rest of it is made flatter till you are happy. Again, fix it with stainless steel wires. Now in adults, normally, as you saw yesterday and even today, the cartilages have adequate thickness, so you don't need the third piece most of the times. Of course, in children who are syndromic or who have very flat or thin cartilages, you need to add one more layer under the base frame, which is called as the projection piece. So you tighten the wires on the posterior aspect, and then cut the excess lengths of the wires off and bend the knots with a 15 number blade. So this is fixation of the lower part of the anti-helix. The knots being cut off and buried into the posterior aspect of the framework. So this is how the framework should appear. Now if you are not going to create a tragus, this is called as a type 2 Fermin framework. So you can leave the inferior most part of the anti-helix free, and you can fixate it to the anti-tragus in the native ear. So I think in this particular video the patient already had a tragus, so I am not sure if I carved a tragus in this patient. But if not, then you just keep the inferior end of the anti-helix free, and you can join it with a single monocryl suture to the base frame or to the native cartilage at the anti-helix. So if you see the thickness, it's around 1.7 1.8 millimeter at the highest point, and then it tapers at both the ends. So understand where the most convex parts are to be created, where the most concave parts are to be created, and that's how you can create a framework which has a good three-dimensionality. Thank you.
Thank you, sir. We'll be now moving through OT1. Bhandari sir, can you hear us? Are you audible, sir? OT1?
Yeah, are you with us?
Yes, sir, we are with you, sir.
So, you've seen the cartilage, or should I show it again?
Sir, show it again, please, sir.
So this is the cartilage. Saline देने का. ये इधर रखा है. So I've fixed the cartilage with the native cartilage here, which was वो क्या कहता तुमने निकलवाया है तो उसके अंदर है. There are so many threads inside. बाल भी है. I'll just come to you. So this is cartilage, and as you can see over here, I've made the tragus also. Can you see this?
Yes, sir.
So this is anti-helix crura, anterior and superior crura. Anti-helix, then it curving around and forming the tragus. Anti-tragus has not been made because it was very hard, we're not able to mold it over here. But then, okay, the anti-helix and the tragus should be at the same level. So it gives a contour which is continuous. So you can see over here it has been fixed, and we have given the direction along the direction of the nose. Nose was like this. So that is how it looks like. Mouth, then sister, there's a bleed here.
Sir, you have used the sentinel suture, sir.
Sorry?
You have used that sentinel suture, whatever Mohit sir was using yesterday. Suture, sir.
Suture for the
cartilage carving.
For the carving?
Yes, sir.
So I have used 4O proline on round body needle. I would start it at the junction of the helix and anti-helix and the basal framework. Go up, come down, so that the knot lies inside. So can you see this? There is no knot outside. It is in between the helical margin and basal framework. All knot is buried inside. So if the knots are lying on the posterior aspect, once you raise it, they also become superficial. So right now you believe that it has gone posteriorly, but once you raise it, they will also become superficial. So it is better. Can you hold it like this? From here. So I'm now using 4O Vicryl. Sorry? This has to be continuous suture because we want to create a water seal. But I have seen like the one who does Ranish. Ranish has come to Delhi and he used the Med4 and temporoparietal facial flap and he applied only 4 or 5 sutures, interrupted sutures. And he was able to make the suction also. I don't understand how he was able to do it. But he was not doing continuous. But I will always do it continuous, and sometimes even with the continuous, there is a leak somewhere. Sometimes this happens. Can you hold this? No, hold it. Chalo, I'll do that. You will not be able to do it. The flap looks healthy, looks fine. सिस्टर एक सक्शन चाहिए अपने को इधर नहीं मिनी वैक No, that way every step is important. The fixation, the position of the ear, the direction of the ear is very important. But in due course of time, what you understand, the carving is not very important. Of course it is important, but making a pocket is extremely important. Like the size of the cavity, and especially the level where you're raising the skin. It should be thin. If it is thick, then the contours will not show. It will not show. And if it is thin, the skin may not survive. So you have to be very careful. आज मेरा एक लेक्चर होगा ना, उसमें मैं आई विल बी टेलिंग एवरीथिंग अबाउट दिस.
Sir, do you normally tuck the edges of the fascia inside to prevent air leak?
Dr. Parag?
Yes, sir.
Yeah, the voice is not very clear. Can you be a little slow because it's echoing over here?
Sure, sir. Do you tuck the lower margin of the fascia inside the native skin pocket, like in the lobule or other areas?
Listen, what do you say?
Do you something of the
What?
the flap, I think. Facial flap.
No, I am fixing it with the subcutaneous tissue, not with the skin. That is what you are asking?
No, sir. I mean, are you taking these sutures edge to edge, fascia to the skin edge, or you are tucking a little bit of the fascia, excess fascia inside?
I'm little bit tucking in, very little bit.
Yeah.
If I want to leave a little portion for the skin, of course the skin would be overlap, but then still. Sister suction आ गया है. And I will be using only one suction for the fascia. Oh, the anesthesia suction. नहीं बेटा इसके वो ड्रेन and you can see almost the exact size of the fascia is very important. You can see this, it is almost the exact size. रोमोबाइट नहीं है तो ले लो, फटाफट ले लो, तब तक इधर दूसरे से शुरू कर दें या नहीं, इसको काट के कर लेते हैं. कोई बात नहीं यार, ये तो कंजूसी नहीं करना, थोड़ा सा कट. Skin hook. That is what I was saying. See, anterior margin, you have to be very careful because you are very close to the artery over here. No, so one has to be very careful that you are actually to the margin. If you go a little beyond the margin, you might take the artery in this suture line. So one has to be very careful. Sister, non-tooth forceps मिलेगा क्या छोटा? सक्शन आ गया, मेरा सक्शन का काम आ गया अभी. क्या लगा दो, इसमें लगाओ. अंदर जाइए। सिस्टम को दे दो, वी आर वेटिंग, टेक ओनली मार्जिन।
पर मुझे डाइट दो।
सिस्टर सक्शन दे दो। हाँ, एक ये लगा के। सिस्टर, इसका वो डालने वाला कहाँ है? कैसे डालेंगे उसका? वो कहाँ है? सिस्टर इज वॉशिंग फॉर द फर्स्ट टाइम। सिस्टर, वो डालेंगे कैसे? वो निकाला क्यों है? होल्ड करो, अभी लेते हैं सिस्टर भी। वो कटा हुआ था क्या?
Sir, I can
ले
see
लो,
that.
sister, एक साइड ले लो।
Sir,
Yeah,
I can see that you kept some space just above the helical rim in order not to strangulate the fascia. Can you give us more information about that?
क्यों नहीं समझ में आ रहा है मुझे? Over here for the
Right,
for the,
sir.
yeah.
Right.
You can see my finger.
Yes, sir.
Yeah. We have created a space, the sulcus. बहुत डेंजरस चीज़ है, इंजरी हो सकता है उससे। सिस्टर, कट करना है। सो ये बाहर आ गया, दिस मच, ओके, एंड इट विल गो बिहाइंड। कट करना है इतना, या इट विल गो बिहाइंड द कार्टिलेज फ्रेमवर्क, पोस्टीरियर टू द कार्टिलेज। थोड़ा बड़ा लग रहा है मुझे। नॉन टूथ फॉर्सअप देना सिस्टर, थोड़ा सा और काटने का। यस, अभी पहले उसको फिक्स कर ले, निकल ना जाए। कोई है सिस्टर फिक्स करने के लिए? सिल्क और एनीथिंग, थोड़ा लूज, नॉट वेरी लूज, इट्स थोड़ा सा हल्का सा पुल।
And sir, you have placed one more drain for the scalp.
या क्यों नहीं समझ में आता? Scalp में the drain has already been put in.
Right, sir.
And I would prefer to put a drain in the chest also. हाँ जी, there is always some collection, especially female. अभी भी डाल दो कुछ। बिकॉज फीमेल पेशेंट होता है ना, थोड़ा सा फैट, वो फैट मेल्ट होके आता है कभी कभी।
Sir, what is your post-operative protocol? How many days do you keep the drain?
So I will do the dressing with a mild compression, and change the dressing after 5 days. But then every day you have to be careful looking after the the suction, and whenever it gets deflated, it needs to be inflated again. That is the only thing which needs to be taken care of. Otherwise, open the dressing after 5 days and take out the drain on the same day. Unless there is a 5 days, unless there is a ooze or something, it is spontaneously coming, which rarely happens. We'll take out after 5 days. Same time. We'll do the dressing complete change.
And do you put the patient on any Ecosprin or any other thing, sir?
No, nothing.
Okay.
Ecosprin for what? To make the blood thin? Ecosprin is it? No, I don't give anything. So anybody giving Ecosprin? I have not heard about it. People are giving Parag?
Yes, sir.
People are giving Ecosprin?
No, sir, we want to ask you.
No, I don't. Okay. I don't give any anticoagulants even in micro also. Micro also we don't give any anticoagulants, heparin or low molecular heparin, whatever you say. We don't give anything. Unless it is a amputation which has been reimplanted. In that situation we only give it. Otherwise we don't.
Okay, sir.
सिस्टर एक छोटा सा वेट गॉज चाहिए सिस्टर छोटा 2-3 वेट गॉज चाहिए बहुत अच्छे वेट अरे मेरा ड्रेन फिक्स नहीं किया ना अभी निकल मुझे लगता है कि पहले ड्रेन फिक्स कर देते हैं क्योंकि एक बार ऐसा हो चुका है कि ड्रेन निकल गया फिर सब कुछ खोलना पड़ा दिस कैन हैपन नहीं होल तो अंदर ही है ना इट शुड बी इनसाइड देन देयर विल बी वेरी फ्यू होल्स लेफ्ट इनसाइड तो ये तो होल इज नॉट विजिबल आउटसाइड नो देयर इज लॉट ऑफ स्पेस बिटवीन दिस एंड द होल्स एक और लगाम घुमा के थोड़ा सा दिल को तसल्ली ज़्यादा होता है सिस्टर ले लीजिए एक आर्टिस्ट मिलेंगे डन कोई बात नहीं लीव इट ये लेना सिस्टर जी वेट मॉप देना है अभी लगाएंगे तो लगेगा अभी सक्शन करना देना ये तो बहुत मोटा वाला है, पतला वाला है सक्शन करना, आर्टी फोर्सेप देना नहीं लगेगा इसमें, इसमें सक्शन आता नहीं ना अंदर जाके. Can you see it now?
Very nice, sir. Super.
So you can see the grooves. Yeah. And this is forming the tragus anteriorly. And we have left behind the skin. So that gives the elevation.
It's looking very nice, sir.
Thank you. Cleaning. ले लो. क्लीनिंग के लिए देना सिस्टर, वेट मॉप नहीं, छोटा मॉप दे दो वेट. आपके लिए क्लीन कर रहा हूँ फोटो लेने के लिए. You can take it now. इधर से भी ले जाओ. हाँ, because it has been elevated. And if somebody can show it, can you see the elevation also? If they can show the elevation.
Can we get a lateral view so that?
Yeah, from here. Can you see the elevation now?
Yes, sir.
Scale देना सिस्टर. So this is almost 1.8.
It's very good, sir. Yeah, yeah.
1.8. Superiority is 1.7. Inferiority is 1.67. So it is okay. Elevation is fine. Sister लीजिए. Graph दे दीजिए. इधर से दिखा दो लाइट की वजह से. Oh, very nice graft. होल्ड करना. होल्ड 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 बच्चे. तो इसको लूप को ऊपर कर लो तो इसे कम दिख रहा है. होल्ड होल्ड होल्ड. So I've been advised to put in glue, but I don't know how to apply the glue. They have hysterically over here, तो ये मुझे बताएंगे अभी कैसे लगाना है. Scissors दो. लगा भैया, ग्लू ग्लू लगा. यहाँ से लगाना शुरू कर. नीचे फिर एक मिनट ड्राई कर लें थोड़ा. सिस्टर ड्राई करना है, वेट. वो ड्राई गॉज दे दो. ये लो, एक मुर्के पे दो सिस्टर फॉरसेप्स. ओके, वेट. Wait.
raise the graft and then underneath it. चलो, we applied Dermabond, which is little different, है ना? Seizure देना sister. ओ सिस्टर छोटी सीजर दो. और सिस्टर एक गॉज में ना बीटाडीन वेट करके रखना, उसका वो बनाएंगे. जस्ट अ मिनट, जस्ट अ मिनट. नॉन कटिंग सीजर दिया सिस्टर. एक सेकेंड, मैं इसको फिक्स कर लूँ ना, वो ऊपर. ठीक है, कंटूर अभी करो भैया. थोड़ी देर दबा लो उसको. थोड़ी देर रुक जा, नीचे कराएंगे हम. लीव इट. सीजर दे दो सिस्टर, कोई अच्छा काटने वाला है. वो करेंगे अभी वहाँ पे कुछ. इधर लगाएंगे. देख, मेरे ग्लव्स मत लगाना, ग्लव्स चिपक जाएगा. फॉर्सेप्स. काटें थोड़ा सा इसको, एक्स्ट्रा है. होल्ड करना. क्या चिपक गया? तो से लेना. मैं बना लगाता हूँ. एक सेकेंड. या ठीक. सिस्टर ये लीजिएगा. दे दूँ आपको, ये लो. एक सेकेंड, ओवरलैप करके थोड़ा काटेंगे उसको. Just a minute. Yeah. Yes. Done.
It's come out very well, sir. It's looking very nice.
Wait. Sure. Yes. लगा. Done. इधर थोड़ा सा लगाएगा. ये done. Wet mouth देना sister. Wet, when I say wet mouth is small gauze, छोटा सा. अच्छा रोमो बैग देना, वही मिनी बैग देना अपने को. Give me the mini bag. Is it holding? So there is no leak.
I think you deserve a big round of applause, sir.
Thank you. चलो अब मेरे को वेस्टर्न गॉज दे दो. बैक्टीरिया इसमें तूने वो लगा दिया इसमें. सिर्फ वेस्टर्न गॉज और छोटा वेट गॉज. वेस्टर्न गॉज मुझे दे दो. ले लिया. एक छोटा, हाँ स्क्वीज मत करो, दो दे दो, स्क्वीज नहीं करना है. What is the time now? What is it? तो ठीक ही हो गया. Not taken much time. I had probably the good assistant, इसलिए जल्दी हो गया है ना. You see this? I'm taking multiple cuts. Yes. ये मैंने तब सीखा जब मेरे स्कूटर का वो ख़राब हो गया साइलेंसर. उसमें टिन की पत्ती ऐसे करके लगाता है. तो मेरे को लगा यार ये यूज़ करना चाहिए टेक्निक. हाँ. So giving multiple cuts. So ये देखिए multiple cuts दिए. So I have learned today that instead of suture, you should fix it with the gums. It is faster. लेकिन महंगा है ना, कॉस्ट होता है उसमें. कितने का है ना, पता नहीं. 100-150 वो ज़्यादा तो नहीं है, है ना. ये कभी अनिशा एक फ़ोटो ये भी ले लो कि ड्रेसिंग कैसे कर रहे हैं. इससे वो बनाया गॉज नहीं कॉटन लो. कॉटन ले लो.
अच्छा फेली बचा था ना उसमें। अच्छा ऑइंटमेंट देना, न्यूज़पोरिन या कुछ ऐसा ऑइंटमेंट छोटा सा और देना मुझे, वेस्टर्न गॉज एक स्ट्रिप काट के ऐसा। हाँ ये काट के दे दो एक, इधर 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 दे दो। कहाँ से? यहाँ डायरेक्टली तो बड़ा महंगा ऑइंटमेंट है यार, न्यूज़प्रिंट लगा दो। एक सेकेंड। लगाओ, खूब सारा लगा दो बस। एक्चुअली क्या कभी कभी लीक होता ना, इट टेक्स केयर ऑफ दैट ऑल्सो। इसमें तो है नहीं, इसमें असिस्टेंट अच्छा तो लीक हुआ नहीं, तो लीक ज़रूर हो जाता कहीं ना कहीं। जैसे वो बीटाडीन का आ गया, बनाया आपने, स्क्वीज कर लिया। सो टेक दिस ऑल्सो। एक कॉटन, कॉटन ये नहीं चाहिए, कॉटन ये चाहिए, कॉटन रुई चाहिए, रुई चाहिए, रुई। स्क्वीज़ करना है उसको, ठीक है। इसमें रख के अच्छी तरह स्क्वीज़ करना है, इसके अंदर से, इसके अंदर रख के स्क्वीज़ करना है। दे दो मुझे स्क्वीज़ करके। सो आई always do the contour dressing. Betadine. कॉटन का अच्छा क्वालिटी नहीं है, ये रजाई वाला है। दे रहे हैं सोचे। जॉनसन जॉनसन का जो सर्जी पैड आता ना, दैट इज द बेस्ट। एंड आई विल नेवर गिव ड्रेसिंग टू माई असिस्टेंट, क्योंकि वो प्रेशर कितना देना, दैट इज़ वेरी इंपॉर्टेंट। अगर आपने ज़्यादा प्रेशर लगाया है सो इट्स ए फ्लैप, और कम लगा है तो भी ठीक नहीं, बिकॉज आई वांट ग्राफ टू बी इन कॉन्टैक्ट विद द fascia, so it has to optimum. What is optimum nobody knows, तो जो ड्रेसिंग करता है ही ओनली नोज इट। जैसे गॉज, जो छोटे गॉज है ना, वो खोल के देने का मुझे। सिस्टर ड्राई गॉज दीजिए मुझे खोल के, ये निकाल दो यार। तो तुम लोग स्टेपलर लगाते हो तो रिमूवर भी होना चाहिए ना, है नहीं? होगा नहीं, क्योंकि मैंने तो हर जगह देखा, कहीं होता नहीं है, सब ऐसे निकालते हैं। ये लो
सर, है सर, है
सिस्टर, और चाहिए खूब सारा।
सर, बहुत अच्छा बना है, सब लोग अपलोड कर रहे हैं सर। बिग अपलोड टू सर।
थैंक यू वेरी मच
सर। वी आर स्टार्टिंग द टॉक ऑफ पराग सर। सर
इधर ओके। जैसे गॉज और चाहिए, बहुत सारा फ्लफ गॉज, और 4 इंच बैंडेज चाहिए। खूब सारा दे दो सिस्टर।
Sir, are you planning for mustard bandage, sir? Mustard bandage you are planning, sir? Hello?
Yeah.
So are you planning for mustard bandage, sir? bandage will you applying that mustard bandage?
Yeah, and give me another 2 minutes. I'll just do mustard bandage. Yeah, with little bit of compression. I was just telling here, people standing, that this part is always done by me because the pressure is extremely important. It should not be too much, it should not be less, it should be optimum. And to quantify what is optimum is very difficult to explain. और मेरे को डायनाप्लास्ट चाहिए होगा फिर इतना लंबा बीच में से डिवाइड करके, जैसे गॉज और दे दीजिए और
लगा
और दे दीजिए। वो ब्लॉक भी लगाना है ना? हाँ, ये लोग लगाएंगे नहीं, ये हम लगा दें। You will have to hold this and then somebody has to hold the head also. Sister, बैंडेज दीजिए और एक गॉज और दे दीजिए मुझे। मैं फिर भी ब्लॉक लगाता हूँ। हड्डी निकली ना 3 यार, बहुत दर्द होता है। बैंडेज अच्छी नहीं है यार, बहुत छोटी है। नहीं, 6 वाला फिर बड़ा हो जाएगा। एक मिनट, एनेस्थेटिस्ट से तो पूछ लो कि उठा लें कि नहीं। एक मिनट है। एक्चुअली इसका मैं वो पिन निकालना था, अभी नहीं निकाला तो कोई बात नहीं। इट हर्ट्स, जो पिन लगा है ना ड्रेसिंग पे हटा देना चाहिए। अच्छा, मैं दूसरा कान फील कर रहा हूँ, वो तो है ही नहीं। कि दूसरा कान तो ड्रेसिंग में नहीं आ रहा, वो है नहीं कान इसका। Five days. Only have to check the drain. And this also is very important. If you tie this very tightly, the bandage will become tight. It has to be just to take out from the eye. Should not be very tight.
Sir, we will start the talk of Parag, sir.
Okay, thank you. Thanks a lot
Thank you,
for
sir.
being with us.
Thank you, sir. Sir?
We have all seen how good results in ear reconstruction look, but at the same time we should not forget that you can have complications also. Of course, when this topic was given to me, I thought it is otoplasty for prominent ear, so I have included most of the slides to show complications of prominent ear correction, but I will also give you some tips about how to perform a otoplasty and also how to correct the lop ear. Actually, when you think of otoplasty, it's a very simple procedure. It is something which takes around 20 minutes per side, and when done properly, it can really be a very satisfying procedure. So what can go wrong in otoplasty is basically these three things. You can have an infection, you can have some kind of hematoma, or you can basically be just using a wrong technique. Now, infection shouldn't happen if you have taken proper aseptic precautions. hematoma shouldn't happen if you have paid proper attention to hemostasis during your surgery. Wrong technique is something which you should be able to avoid by attending workshops. So once any of these three complications has happened, then you land up with either of these scenarios. You can have resorption of the cartilage, you can have warping of the cartilage causing deformity. This can then create partial defects in the ear framework, and all this can lead to scarring of the overlying skin, and then basically you are looking at a patient who is going to follow up with you for the rest of your life. So the primary causes of complications are basically due to wrong technique, or it can be due to wrong surgeon. Now what do I mean by wrong surgeon? I'll explain to you. So wrong technique is basically a technique where you use an anterior approach. Now always remember, when you want to pin the ear back, it makes sense that you are going to take stitches on the posterior aspect, but there are some techniques where they have described the incision on the anterior aspect. Now you have to go through the thickness of the very thin cartilage to reach the posterior aspect. So an anterior approach is something which is totally wrong, and so are techniques where you rely on anterior scoring. It is just going to cause scarring. It is not something you should use for pinning back the ear. So anterior approach or anterior scoring is something you should avoid. And the other thing you should avoid is any excision of the cartilage. Now sometimes if you have a over projected ear, or if you have a concha which is over projected, there is a lot of temptation to excise a small disc of cartilage to lower the concha or to reduce the projection of the concha, but then you end up creating a very sharp edge. If you look at your own concha or the concha of your neighbor, whatever is available, you will see that part of the ear is very smooth. It does not have any sharp edge. So this cartilage excision is something which creates more problems than it solves. This is a picture from Madam Firman's textbook, and you can see that these are all complications of otoplasty. Now, of course, we believe that all of this was done with good intention, and nobody wants to have complications like this, but they are really ghastly complications. I mean, this is still okay, but this loss of antihelix, again loss of antihelix and a contracture in the concha, loss of the helical rim along with the antihelix, completely damaged helical rim and collapse of the central 1/3 of the ear, collapse of the central part of the ear, and antiversion of the lobule. All of these are complications that are very much possible, and we need to know how to deal with these complications. Now, what do I mean by wrong surgeon? So, whenever I get a patient who comes to me with any kind of complication of the otoplasty, I normally just take a look at the opposite ear. In life, you are generally allowed to make one mistake, but if you have made the same mistake on both the ears, then definitely it is a problem of technique. So, either you may have had a very aggressive approach to correction of a prominent ear. You may have placed sutures very tightly, and that could have caused deformation of the cartilage. Maybe the hemostasis was inadequate. Maybe proper attention to sterility was not paid. Sometimes you also may have made a wrong choice of sutures. So don't use sutures which have poor knotting, or where the knots are going to poke out through the skin, because this skin is as thin as a tissue paper. If you use any suture which is thick, then it's going to keep poking out of the skin and eventually extrude. And we always have to learn to bury the knots properly. You saw even with Prolene what Bandari sir showed us, that the knot was between the two portions of the framework, not really on the posterior aspect, because the Prolene does cause a bigger knot. I'm sure all of you have used Prolene at some point of time in life. So knots have to be buried properly, as otherwise this can lead to problems with healing. So the best approach that one can have when you get a patient with any kind of complication is to treat it like a partial ear reconstruction. Now, when you have to reconstruct ear, of course, you need costal cartilage. So that will involve some amount of counseling of the patient. That look, maybe the primary surgery has not gone as planned, and now we are in a scenario where we need to do something to salvage the shape of your ear, and costal cartilage is the first choice in majority of cases. Again, you need to first make a pattern of the normal ear so that you don't end up creating a ear which is bigger or smaller. So pay strict attention to symmetry. And the smaller the defect, the tougher it is to reconstruct. So if you have very small defects, don't think that it's a walk in the park. A smaller defect can really give you sleepless nights, and it sometimes is very difficult to create the smaller concavities and convexities in a small defect. If you have a defect like this, which is just involving the helical rim right here, and the helical rim has just got folded, then what you can do is you can use a conchal cartilage. So you can just take a rim incision, unfurl the skin, open up the skin, see the damaged portion of the helical rim, and you put a piece of conchal cartilage for support, and that's how you can create the shape of a normal looking helical rim. Again, another example of Dr. Furman's textbook, where if you have a ear which has deformity of the upper half, then it is not only a deformity of the helical rim, it is a deformity of the antihelix because it has broken here. It is deformity of the scapha, there is no scapha, and you need to then take care to make a reconstruct which goes all the way till here, because only then you can control the plane of your ear. If you make the lower part very small, maybe till here, then it may not maintain the uniplanarness of the ear. It can antivert or it can change the plane. So then again you can use the same incision of the scar, extend it if required either inferiorly or superiorly to deglove the skin, put your fresh cartilage framework in that pocket and apply suction. Sometimes if you feel that you need an additional projection of the Y of the antihelix, you can place an additional piece of cartilage graft here to give additional projection, and then in the second stage you can work on the elevation if required. Similarly, if you have a defect which is something which is involving not only the helical rim but also the scapha, when you draw the shape of the opposite ear, you can exactly make out what is the defect that you are dealing with. So you take out a small piece of cartilage, maybe the seventh rib. You create two components for the reconstruct. One which will form the base frame and a small antihelix to lie on top of this base frame. Take an anterior incision, make a tunnel to place the new framework, and that should give you a good result. Similarly, if you have damage of the antihelix, Y of the antihelix, you can take a direct incision and expose the damaged piece of cartilage, remove the damaged portions of the antihelix, insert your new cartilage, and you should be able to get a good contour. So reconstruction of the antihelix is usually required when someone has had a complication of otoplasty, because in our country we don't do that many number of otoplasties. We fortunately don't see these kind of complications as much as they do in the European countries. So again, completely damaged antihelix, and you also need to have depth. So you need to choose the seventh rib, which is also going to give you depth of the concha. You see in the profile the depth, and after you replace the damaged portion of the cartilage with a new piece, then that's when you will get a normal shape. So if you have a patient who comes to you with this kind of a deformity, which is not very evident just by looking at the profile view, the first thing you do is look at his opposite ear, make a tracing of the opposite ear, and when you superimpose that tracing on this side, you will realize what is the actual defect. So the apparent defect may not be much, but the actual defect is this. And then you can take an anterior incision and place the new cartilage here, where it will create the antihelix and the scapha. Another patient who came to me with a complication following otoplasty, and that otoplasty had overpinned the ear, so it was too much pinned back. So there was a sharp edge of the antihelix, the posterior border of the antihelix, and plus the helical rim had also kind of bent. So the defect was of the posterior wall of the antihelix and also the helical rim. So I took an incision like a type 3A, what I showed you in the morning, removed the damaged piece of cartilage and inserted a fresh piece of the costal cartilage. So the take home message in any kind of otoplasty that you are performing is that you should normally err on the side of caution. When the patient came to you for otoplasty, he did not have any pre-existing deformity, so it is not like microtia. So for patients who have a normal ear, it is not acceptable for them even to have 1% problem. So it's better to err on the side of caution. Definitely there is nothing like an anterior approach for otoplasty. You please avoid an anterior approach and avoid over aggressive suture tightening. If you feel that it is just the strength of your suture which is pinning the ear back, it is not how it works. You are also going to weaken the posterior aspect of the cartilage, and that actually helps you turn the ear backward. So avoid over aggressive suture tightening, because it will only cheese wire over a period of time. And if you feel that the cartilage is getting deformed, maybe you need to intervene early, remove those sutures and let the cartilage bounce back to how it was before, because if you just keep waiting on it, the deformity will reach a level where then it will become irreversible. So this is how you deal with complications of otoplasty. Now that brings me to the discussion about otoplasty. So there was a request for cosmetic otoplasty, and now I don't have a video at the moment to show you about how to perform otoplasty, but how I perform otoplasty is by the Mustardi technique. Now a Mustardi technique means that you need to take an incision which is in the post-auricular sulcus, then you deglove the skin on the posterior surface of the ear till you reach the margin of the helical rim. Once you reach the margin of the helical rim, you take a 24 number needle and you dip it in methylene blue, and then you pin the ear back with your hand and you see where exactly is the maximum point of projection that you want to deproject. So with the methylene blue dipped needle, you make a point at the highest point, then you make another point in the middle part of the ear and a third point lower down. So there are normally 3 sutures which are required to turn the entire ear back. If you just take 1 or 2 sutures in the upper part, then this looks pinned back, and the lower part of the ear becomes even more antiverted than what it was before. So at least 3 sutures, one for the upper end, middle end and the lower part of the ear is what will help. I normally use a 40 Prolene to do my otoplasty. So once you identify what are the 3 points that you want to take your suture on, the next step is to take a number 15 blade, and then you just keep on smoothing the posterior aspect of the conchal cartilage with a 15 number blade, so that sequentially you are weakening the posterior surface of that cartilage. You will see very fine cartilage dust which kind of gets created when you keep moving your blade back and forth, and also keep turning the ear backward as you keep doing it, because you don't want to reach the anterior aspect. So it's not a complete through and through kind of weakening of the cartilage. It is, you can say, you want to weaken it by say 75%. Once you have achieved the ideal weakening of the posterior surface of the cartilage, then of course you will take 2 type of sutures depending on of course how projected the ears are. The first set of sutures are going to be between the conchal cartilage and the conchal cartilage. So those are sutures which are just going to pin back the upper portion, middle portion and lower portion of the ear. And then there is another layer of or another row of sutures that you will take which will essentially be to fix the concha to the mastoid area. These are called as conchomastoid sutures. So you can use the same 30 or 40 Prolene to take conchomastoid sutures. Now sometimes the muscle layer in the post-auricular sulcus is very bulky and you don't really have much space to pin the ear back, in which case you need to excise a small sliver of the muscle in the post-auricular space before you can take your conchomastoid sutures, because then that creates a space for the ear to move backward. Now once you tied your conchomastoid suture, sometimes there is an excess skin that remains at the level of your incision, so that small wedge of skin may need sometimes to be excised, and once you have done that, then you can close the incision using an absorbable suture such as a 40 monocryl. After you do the otoplasty, you should ask the patient to wear something like a headband. So there are those woolen headbands that people wear for during the cold climate. So you can ask the patient to wear a headband at least for 2 weeks post surgery, and tell the patient not to keep pulling on the sutures unnecessarily, because in the initial part of the healing the sutures are still quite raw, and if you keep pulling your ear forwards, then you can easily cause breakdown of these sutures. So normally for an adult patient you should be able to do an otoplasty under local anesthesia. You don't really need anesthesia. If it's a child and definitely an uncooperative child, then it's better to do it under anesthesia. And in children it's also better to keep the ear bandaged for a little longer, because younger children are not able to take care of their ears as much as you would want them to. So otoplasty is a very simple procedure. I will see if I can show you some video on otoplasty tomorrow when we meet. Now when you have a case of lop ear is basically a ear which is folded upon itself. Now again you have to use the principle of the halves and the planes. If you have a ear which is so floppy that it is folded on itself and it is involving more than half of the size of the ear, or you have a lop ear which is involving more than 2 planes, then you need costal cartilage to reconstruct the ear. If you have a lop ear which is affecting only the helical rim or only maybe 25% portion of the ear, then you can manage to correct the lop ear by treating it either as a projected ear by doing some kind of an otoplasty, or you can add a small piece of conchal cartilage to give support to the helical rim, like how we saw in the partial defect. If you have a lop ear which is really folding upon itself and involving more than 50% of the size of the ear, then you need a stiffer material such as a costal cartilage for reconstruction. Ideal age in that case, if you want to use costal cartilage for a lop ear, it should be anywhere after 8 or 9 years of age, because below 8-9 years of age the cartilage is going to be very delicate and floppy, and it may not serve the purpose. So you'll need to counsel the patients accordingly. So correction of lop ear is something which is easily doable. You can deal with it either by using conchal cartilage or costal cartilage. And now for newly born children, if you have a neonate or a child within the first week of birth who the parents bring to show you, and the child has some kind of lop ear, then there is a system called as the ear well system. So ear well system is a siliconized kind of mold where there is one base plate which fits in the post-auricular area. There is a small silicon tube which goes in the groove of the helical rim, and it has like a clip-on. So that ear well system has been developed specifically to correct lop ear deformities. So they have found that the hyaline cartilage in immediately after birth is quite moldable, and if you start using this ear well system immediately as soon as the child is like a 1 week old or 10-day-old infant, then you can easily mold this cartilage. And after wearing the ear well for 6 weeks to up to 3 months, there have been significant improvements in the shape of the lop ear. So if a parent comes to you early on in life, or you have a pediatrician friend who refers a case who's newly born, then the ear well system is something that also can be used for correction of the lop ear. So if you have any other questions related to any other type of deformity where you want to ask something, feel free to ask, and I'll be happy to help you if I know something about it. Any other deformities that you feel we could have discussed or anything? Congenital lobular defect, like a split lobule, absence of lobule. Well, it's not very common to have absence of lobule, because even in microtia, if you see, what is present is just the lobule. So it's not very common to have absence of lobule, but of course you'll have cosmetic problems of the lobule, such as a split lobule or a lobule which is antiverted or very small. So for split lobule, for example, if the cleft in the lobule is not involving the entire length of the lobule, like from the border of the lobule till the antitragus, then you can just do like a Z plasty and join the two surfaces. But if the defect is through and through, it extends all the way to the antitragus, then sometimes you need a little bit of support. So you can take a small piece of conchal cartilage from the opposite side and use it as a sandwich, because skin contracts. If you just suture the lobule over a period of 3-6 months, it again creates a notching. So if you can place a small sandwich of conchal cartilage and then suture the skin on top of it, it holds for a longer time, or it doesn't cause any deformity. So that's how you can treat a split lobule. If you have a lobular defect per se, like what you're saying, absent lobule, then what I showed in partial reconstruction, you can use a small piece of costal cartilage in 2 stages. In the first stage, you bury it in the post-auricular area and then elevate it after 6 months. That's what you can try. You can, yeah. But then you have to, you need sometimes to put support. That's what I was going to say, yes. So if you do a bilobed flap, one, you are going to have some amount of scarring from where the donor area is, and of course it is not a very stiff kind of flap. So it depends really on the defect. If it's a small defect which you feel is a skin only defect, manageable, but just by skin, bilobed flap can be a good option. But if you feel it's a big defect and needs support, then you use cartilage. It makes more sense.
Sir, when we are correcting in prominent ears, what will be the sequence of tying the knots? Sir, can you just describe?
So I normally tie it from top to down. So tie the uppermost suture first, then the middle one, and then the third one. It is always a good idea to pre-operatively ask the patient to stand in front of a mirror and make you show how much pinning back they want to have, because you don't want to end up pinning the ear too much behind. So you ask the patient how much is the area that they want, or how much is the pinning back that they want. So you first tie the uppermost suture, then the middle one, and then the lower one. And again, if it's under local anesthesia in an adult, you can show the patient immediately on table, make the patient sit up and see in a mirror before you apply your mastoid dressing. So if any modifications need to be done, then they can be done at the same time. To correct prominent ear, 8 years and above. Less than 8 years, again same problems, the cartilage is not resilient enough and your sutures may cheese wire or give way. So 8 year onwards, I think, and the child is also able to cooperate a little better. In a very young child, the mastoid dressing becomes a problem, then the sleeping becomes a problem. Children are not able to cooperate with the post-operative instructions, so better to operate once the child is 8 years old.
Just to conclude, I think just to become Abhimanyu, so you know how to manage the complications rather.
It's very, very
so,
important.
Yeah,
true,
once you know how to manage the complication, that gives you confidence.
Yes.
And to cases.
Absolutely, absolutely. I think when we are starting out in practice, we should not attempt to do, secondary or revisional cases, and stick to simpler cases where you feel confident in giving a better outcome to the patient. At any point of time, if you feel that the case is too tough, or there is likelihood of you not being able to deliver the appropriate outcome, we are all there. You can always message us or email us, and we can help you maybe in some way in doing the surgery. Thank you.
Thank you, sir.
Sir, share a few words about today's surgery.
So we can, I believe, discuss this out because this patient had chest wall deformity and the cartilage was concave on the left side. So I thought we'll not take the 8th costal cartilage, but like, because I always give inframammary incision, and when you give inframammary incision, it has to be large incision because cartilage otherwise lying very low. So it becomes very difficult, tedious dissection unless you give incision exactly over the cartilage. So in this patient, it was lying very low. Sometimes the framework is like this, and sometimes it is like this. So if it is like this, it's lying very, very low. So I have taken 6th and 7th costal cartilage. It was very broad. So I couldn't make the. So the advantage was this patient had a bilateral microtia. So I could make little smaller here. So I could make the basal framework with the 6th and 7th. At the same time, leave a rim which was used for helical formation, helical augmentation. And I've taken a long cartilage. So, and with the same cartilage, 6 and 7, I've carved out the anti-helical margin also, and also the tragus and augmentation. So it was quite a bit of cartilage. And whatever is left behind, as I've mentioned yesterday also, I always do subpericondral dissection. And once we have taken out the cartilage, and after carving whatever is left behind, it usually quite a bit of cartilage in pieces. So diced cartilage was put in back again after the perichondral pocket was formed again. And believe me, if you see the patient after 3 months, there is no chest wall defect. Deformity is something different. So if you take out the cartilage, people say in younger patient, as the child is growing, there can be deformity. I'm not talking about the deformity, I'm talking about the defect. In adult patient where the cartilage is fully grown, and once you have taken out the cartilage with perichondrium, there is definitely a defect over there because it will not grow. But if you leave behind the perichondral and make a pocket and fill it with the cartilage, whatever is left behind, it gets solidified and there is no defect. Of course, you cannot take out the cartilage again from that portion, but there is no defect over there. And there was a problem in this patient also because there was only one vein. Maybe there was a long scar, as I was mentioning you. So if inadvertently somebody is injured the vein, so all the veins draining that vein will ultimately atrophy. They will go to some other places, some other side. So the veins were not visible in spite of the fact we have not left any vein in the flap or underneath. But we would be able to find a vein. I hope it will serve the purpose. So we would be able to find the artery, vein is on the spear surface. As I'm showing you, there is a definite plane of cleavage. And what is extremely important, the size of the temporoparietal facial flap is extremely important. If you are on the side of taking more of the fascia, then also the grooves will not show because it will fill the grooves because it is extra. And if it is short, then also it will not show because then it will tend toward the grooves. So the size is extremely important. Raising, of course, is very important, but size, cartilage carving is important. So everything is very important. Now, if you are doing microtia like Dr. Parag has done, so the making of the pocket is extremely important. When you're raising the flap, it has to be a thin flap so that it goes into the contours and the contours show through it. But at the same time, it should be thick enough to survive. Because it is very thin, it might show, but then it may not survive. So that is extremely important point, and good pocket, because it may be a good thickness which will otherwise survive, but if it is tight and you apply this suction, there is an extra pressure to the skin, then also it dies. So these are finer points which one should actually take care of. Yeah, if anybody wants to ask any question, not related to this, otherwise also, any deformity. People say, see, the cartilage survives by diffusion. If you leave behind the pericardium, the vessels will grow into it. So the vascularity in that situation would definitely be better as compared to when you don't have any pericardium all around. So people say, like, if you are doing in a case of child around 7-8 years and taking the pericardium, it might grow with the growth of the child. That is one. And the resorption rate is less as compared to if you are doing a subpericardial dissection. So people have done it, but so many people are doing with subperitoneal dissection, and I've been also doing for quite some time. I have seen resorption only when we have seen there was a little bit of redness which settled or the skin was tight. In those situations, I've seen resorption. Otherwise, in my experience, not much of the difference. I used to take pericardium both the side initially. That was Brent's. He was using pericardium both the side. I've switched over gradually as I matured. So I don't find any difference. But if you can probably make the pericardium good for the blood supply, but then at the same time there is a defect in the chest wall.
That removing the perichondrium or keeping a part of the perichondrium doesn't really change the outcome in terms of resorption. As I said, taking the anterior perichondrium along with the cartilage, I feel gives more stability to the synchondrosis. So that is one thing. And by leaving the posterior perichondrium behind, you are able to safeguard the pleura better. So I think what I do is like a middle approach, somewhere where you get benefits out of both the things. Now I have operated on many cases with bilateral microtia. And I have not really seen too much of chest wall deformity unless the child is very lean and there is no muscle mass to cover the rib cage where you can clearly see the ribs. Only then you may see a little bit of depression, especially in bilateral cases. So if you are careful not to go all the way till the xiphisternum, then usually the stability of the chest wall is not disturbed, and normally you shouldn't get chest wall deformity.
So it looks like there is an overdose of studying every child. So thank you very much. We'll see you tomorrow again. I believe it's done today.
I know it's been a very hectic day for all of us, but there was one talk actually which was supposed to happen yesterday by Bhandari sir. It was supposed to be on post-burn ear deformity correction. So if everybody is willing to go ahead with that as well, then we will proceed with it, because we don't know when we will have him here again with us. So, sir, please. Thank you, sir.
Request Parag sir and Prithviraj sir to chair the session.
So taking the name of Sri Ganesha, we'll talk about the external ear reconstruction post-burn deformities. External ear, as you understand, is a very complex cartilage framework. It consists of a complex cartilage framework which in turn is covered by a very thin layer of surface tissue and skin. And quite often the people will ask me, majority of the patient you will accept that who come for the ear reconstruction, they have deformity of the face also. So post-burn deformity of the face and even asking for the ear reconstruction. But this is also true that patients, they want ear reconstruction in spite of the fact there is a deformity of the ear. And this is because they want to adorn their ear with variety of ornaments, especially females. They want ear because they want to adorn their ear with variety of ornaments. And I just want to share this anecdote with you people. When the two ears are put side by side, it forms the shape of a heart. And interestingly, the word ear sits right in the middle of the word heart. So there is a way to the heart, you have to go through the ear. So ear is important, and you can only understand the importance of ear if you have lost one or if you have a deformed ear. So there is a definite need to reconstruct the ear. But the reconstruction, as you in the morning Dr. Pralas was saying, it is extremely difficult thing. I do a lot of rhinoplasty, do a lot of microvascular surgery, but I believe ear reconstruction is one of the most difficult surgical intervention taken by a plastic surgeon. And it is because it is a complex cartilage framework. Difficult to carve out an ear framework out of costal cartilage. Then once you've taken out a carve, it should exactly look like the other ear if it is unit deformity. And what is extremely important, the requirement of skin is always very high, which is most of the time not there, especially in burns because it is scar, so the skin is not available. And because it is a multi-stage procedure, initially used to be 4-stage, now it is 2 or 3-stage procedure. So that means it is more prone to complication. Even a minor complication at any stage can completely change the outcome of the reconstruction. So you need to require a great patience both on the part of the patient and the surgeon. As you understand, Sushruta started it, then Tagliacocci, Harold Gillies. It was basically the Tenjer who started ear reconstruction with the costal cartilage framework. Now, if you have skin normal, not really very simple thing, but comparatively simpler because you have the skin available around, and you can reconstruct with the costal cartilage. This is how the patient looks like, reconstruction comparing with the normal ear. So now the patient where reconstruction has been done with the costal cartilage with the normal ear. But if you have a deformity like this, then it is extremely difficult because everything is scarred over there, and that makes it extremely difficult. So what should be done? Basically, what are the raw material which are required for ear reconstruction? You require an ear framework and a skin to drape the ear framework, which has been carved out of costal cartilage. Now when you talk of ear framework, you have the choice of using autogenous or non-autogenous. Autogenous means autogenous costal cartilage, or it can be silastic or Medpore. Silastic has gone down because of the high rate of extrusion and infection, so it is no longer used. Now the Medpore is porous, it gets incorporated in the tissues. Actually the vessels actually grow into it, and I have read an article where the Medpore got exposed, and because the granulation tissue has grown into it, he had actually applied the graft over it and took also. That was a paper published in PRS. But I believe it is exposed, needs to be taken out. But then this was the thing, maybe it was published by Ranish, who was propagating the Medpore, and Ranish says I have done the cases done by Brandt, and Brandt says done the cases done by the Ranish. But Medpore will still, I would say, needs more time to be established as a real substitute, and believe me, I believe it will never substitute an autogenous costal cartilage. But then you can have few indications when the patient is presenting very, very late, is totally ossified, and it's difficult to carve out a ear framework out of costal cartilage, then probably Medpore can be thought of, think of. Then if the costal cartilage or both the sides have already been used, then there is no choice, you have to use the Medpore. I have read one paper where he has reconstructed the total ear with the septum and other side conchal cartilage. I don't know how it is done, but somebody has done it. And third, if the patient is not at all willing for the costal cartilage. So Medpore should always be covered with a temporoparietal facial flap to give extra precaution. So my choice always is the costal cartilage. Now when you are making ear, the side direction type of the framework to be used and type of skin cover extremely important. These are pre-operative planning, which is extremely important as you understand the direction of the ear is direction of the nose. Sometimes it is 20-degree vertical. Now what you do in case of microtia, you trace the normal ear. This is used for the ear carving, and then you trace this outer template and trace out the microtic vestige, which will exactly fit over the ear framework. So now this template, when you are tracing it over the microtic vestige, it should be cut at the right side and in the right direction. And then you trace out the microtic vestige and make a slot. Now this can be autoclaved or this can be eostelized. Now this will help you out in the operation theater in deciding the size and direction of the normal ear without a need to see the normal ear. So that is how it can be done. Now if you have a deformity like this, how would you decide the position? You feel for the TM joint, it should be just posterior, that is the external meatus. Feel for the angle of the mandible, draw a vertical line. The ear is to be made posterior to that. So you now know the position of the external meatus and the ear position, and this is how you decide the position of the ear in case of when the meatus is also not there. And most of the time the highest limit is at the level of eyebrow. That is how you decide the position. So these are the templates which will be helping you out in deciding the size, direction of the ear. Now these are three stalwarts in ear reconstruction: Brunt, Burt Brunt, Satoru Nagata, and Francois Famin. Now all of them has contributed in ear reconstruction, especially the carving. So we will be discussing. Something went wrong. Okay, I'll use this. So there are a little bit of difference when you are carving out the costal cartilage. We'll be briefly discussing what is the difference between these three techniques. Now the age, Brent says it can be done at the age of 6 to 7 years when majority of the ear has already grown. Nagata and Famis says that after 10 years, or if the chest circumference is more than 60 centimeter, that is the right age when you have enough costal cartilage for a quality fabrication work. Now the Brunt will take 6, 7 and 8 costal cartilage, 6 and 7 for the basal framework and 8 for the helical rim. Nagata and Famin will take 6, 7, 8 and 9 costal cartilage. So again the basal framework is 6 and 7, 8 for the helical rim, 9 for the antihelix and the formation of antitragus and tragus. Now this is very important. Brunt will take cartilage with pericordium intact on both the sides. That means he is doing extra pericordial dissection. On the other hand, Nagata, which I have done today, he will do subpericordial dissection, make a pocket again, and then whatever is left behind, he'll fill the pocket with the leftover cartilages. And he believes that there will be no chest wall deformity after you made the pericordial pocket and put in the whatever the cartilage left behind. And of course, because the pericordium is intact, so there is less likely chance of injury to the pleura. On the other hand, Famin is taking antipericordium with the cartilage. Posterior pericordium is intact. That means again the chances of pleura injury is very little, but again there are chances of chest wall deformity. Brunt surgery is little comparatively shorter time. Nagata Famin is longer. Famin actually takes less time. Then the Brunt will take contralateral, Nagata will take ipsilateral, the Famin also takes ipsilateral. Now my preference is contralateral. I will take subpericordial dissection, make a pericordial pocket, and then fill the pocket with the whatever is left behind to avoid the deformity. As you can see over here, you have taken 6, 7, 8. There was little hypertrophy in this patient, but as you can see, it's a thin-walled patient, very, very thin patient, and you can see there is absolutely no deformity. So this is very surprising. He's a very thin built patient. Similarly, another patient where you've taken a submammary incision and there is no chest wall deformity because we have made the pericordial pocket. So with the help of template, you carve out a framework. So this is just to show that this is done and this is how you make out the. Sometime if it is very broad, even the root of the helix can be carved out with the same thing. Now what is basically done, this is like the root of the helix can also be made with this. Now what you've seen it today and yesterday also, the 6th and 7th cartilage is used for the basal framework. When you're making the basal framework, you want to make the triangular fossa and scapha as wide and as deep as possible to make room for the draping skin or the temporoparietal facial flap. Then the helix and antihelix, they are augmented, superior inferior quiver. So that means basal framework 6th and 7th costal cartilage. Helical margin, superior anterior and helical margin, antihelical margin is augmented. And of course, the continue with the antitragus and tragus formation with a separate piece of cartilage. Now, sometime if the tragus is not required, you may not reconstruct it. Then what you can see in a small piece of cartilage, I some time put in this, which for me does to give elevation to the root of the helix, because I have seen in most of the time the root of the helix does not show properly. So if you give an extra piece of cartilage over here, so it actually gives an elevation to the root of the helix. And if you have enough skin, or if you are using a temporoparietal facial flap, then a piece of cartilage can be applied on the posterior aspect of the ear framework which you have already carved out. Now so far as the suture, you can use a stainless steel wire, or you can use Prolene suture, which you can see over here, Prolene suture stainless steel wire, or you can use a nylon also, which you have seen yesterday Dr. Mohit was doing. I always take this Salastic block which helps me out. Now coming to the skin. So this was the cartilage part. Now in case of burn, that is the most important part, and rarely you will find a patient when you have a post-burn contracture and rest of the face is absolutely normal and you have a skin which can be used for draping up the cartilage. This is very rare in case of burnt patients. Now if it is scarred but still you have some area which is left which can be expanded, you can put a tissue expander and then you can put in the cartilage. But if it is scarred like this, then it cannot be used. So then you look for a superficial temporal artery, and if it is palpable, then you use a temporoparietal facial flap, turn it down and cover with the thick split skin graft. If it is not palpable, you can still go with a random pattern flap, 1:1 ratio, but then there is definitely, you have to keep the fingers crossed that there can be necrosis of the flap, especially in the distal portion. Now if it is not possible, if it is not present, then you have to go for a free temporoparietal facial flap from other side, or you can have a facial flap from the forearm for reconstruction. Now we have just discussed the temporoparietal facial flap, which is based on the superficial temporal artery. So I am not going to go into detail of this, which you already discussed yesterday, accompanied by the vein. So I think I'll skip this portion. Now this we have already discussed that it has to be an optimum size if you are using a temporoparietal facial flap. Skin cooptation is always done with the suction catheter. No bolster sutures are applied, although the Nagata uses bolster sutures in case of microtia. But we are always very scared of using the bolster suture, the chance of necrosis. But the Nagata uses it and then cover with the glycine acryflavin wool with mild pressure. Dr. Mohit doesn't do the dressing and he also shows the good results. So the choice is yours, and sometime as we were discussing yesterday, if the grooves does not show in due course of time, you can probably inject a little bit of Canacort over here. This is like, we have done around 1,000 cases, published extensively in international journals, clinics and plastics invited articles. And now what I wanted to say over here, this was a patient of post-burn deformity. You raise the temporoparietal facial flap, the framework carved out of costal cartilage. No, something wrong has happened. I'll just, no, nothing over here. I think I'll mix up over here. We'll come to that again. Okay. So this was a patient which what you can see over here is the portion which is grafted was totally raw. So after the area has been grafted, this was the deformity the patient has. So we raised a temporoparietal facial flap. What you can see is good vein, which sometimes is difficult to find. It is, we can see it is very superficial on the facial flap. Art is lying entirely. So it was turned down and coaptation done with the suction catheter, then covered with the thick spherical graft, and this is how the patient looks like pre and post-operative reconstruction after 1 year. This is how the patient looks after 2 years. Now this is what I want to tell you. This is pre and this is post with costal cartilage and temporoparietal facial flap. But this is how the patient looks like immediately after the reconstruction. There is a lot of edema and you are actually worried what is actually happening. Because in the operation theater you are very happy when you get the contours. This is after 10 days, then this is after 1 month. Gradually the edema goes down and the grooves start appearing, and this is now after 2 years. So you actually expect the result with temporoparietal facial flap after 1 year. So this is to be told to the patient, and you must also know that this is going to take some time. Another patient who had lost ear and we used a temporoparietal facial flap. This was a chemical burn. He is a doctor. Accidentally the acid fell over his ear. So, and he was very old. He was around 45 years. And as you can see, the ossified cartilage over here. You can see the ossified yellowish. This is all ossified. It was so difficult to carve it out. So this is temporoparietal facial flap. Again, coaptation done with the suction catheter, and this is, and you can see no grooves visible after 10 days. Then gradually will start appearing 8 weeks, and this is 1 month, 2 months, and this is how the patient looks like pre and post, maybe after 6 months or so. This is after 1 year. Another patient who lost ear, and then again we've used a temporoparietal facial flap, and this is how the patient looks like. Now this was a very old patient with everything is awesome. Can you see this basal frame is totally calcified? It is yellowish in character. It was extremely difficult. We have given multiple cuts in the helical margin also to mold it, and then temporoparietal facial flap. So the site, size and direction of the ear is extremely important when you are reconstructing. And you can see over here the exact site, the shape is extremely important when you are thinking of reconstructing the ear. This is a post-mobile deformity. This is pre and post other side. And this patient, both ear has been reconstructed, but they are not exactly matching. Sometimes it becomes very difficult. Now this was a scar region, temporal artery was not there, so we raised a random pattern temporoparietal facial flap, and this is how the patient looks like. Another patient, random pattern flap. This again we had a random pattern flap for the reconstruction. Now what is extremely important when you are reconstructing the helical margin, it should be firmly fixed. Now if you are using a stainless steel wire, the fixation extremely rigid, it does not move. But if you are using Prolene or nylon, you have to apply multiple sutures, otherwise in due course of time it can slip. As you can see over here in the lower portion it has slipped entirely. So it needs to be fixed very nicely at multiple places to avoid these type of complications. This is pre and post and the elevation. So another patient where the temporoparietal facial flap has been used for the reconstruction. And this patient we have used a Medport. The patient was not at all willing for the reconstruction with the costal cartilage. And this is how, this again is after 1 year. Now this patient had very severe deformity, all over scarred. We put in a tissue expander to take care of the bald area. So there was no point to take a temporoparietal facial flap. So what we have done, we have put in a tissue expander in the forearm and then reconstructed the ear in the forearm, and this is how the patient looks like. It's an ear which has been reconstructed in the forearm. Unfortunately, the patient did not come in the corona period. I don't know what happened to the patient. This was pre-corona and he never came back for the next stage. But it was a nice reconstruction, and I thought he would have come. I would have shown it to you with the free flap. It's another patient where the reconstruction done. So I think this finishes. So if you do a pre-operative planning, judiciously execute the technique, I think desired results can be achieved in majority of the patients. Thank you very much. Yeah, we can. अगर थके नहीं है तो पूछ सकते हैं.
The cartilage, because even after rigid fixation there are definitely very minute spaces between the two cartilage which we join, even with be it steel wire.
There will be fibrosis in between the two, and they get stuck because there is a gap in between the two. There is a tissue here, there is a tissue here, so they will try to join. So there is a fibrosis in between, because I have operated one of my patients because of the infection, and I have seen there was a lot of fibrosis between these sutures but it is always advisable to apply as many sutures as possible. If you are working as a professor, you can ask ultimately you have given the sutures, then ask your resident to put in more sutures while you are doing something else or having a cup of tea. So it is better to put in as many sutures as possible.
So the tissue ultimately grows between the crevices.
Vishwadeep is my student. Maan hi puchta tha, sawala puch raha hai. Okay, he's become faculty now. Yeah.
Sir, in post-op periods, if cartilage gets exposed, so sir, there is any step-ladder approach to follow to tackle that situation post-op?
See, it is very difficult to decide. If it is very superficial, you think that it may heal of its own. It is not deep. Then you can maybe applying the T-back and hope for the best. But slightest of the doubt, if you believe it is going to be full thickness, don't wait this to happen. Take the patient immediately, excise the necrosed portion, and do a local rotational flap or whatever flap is available there. So ideally should not wait, because I have seen if you wait, then you are doomed. So it is better to err on the side of excising and putting a flap.
Thank you, sir.
Right then, thank you very much. We enjoyed, and I hope you people also enjoyed the workshop. Thank you again.
Thank you so much, sir. I'd like to thank Bhandari sir and Telang sir and Mohit sir once again for 2 days of great operative workshop. We have learned a lot. It has been truly inspiring and enriching in every way possible. I'd also like to thank all the delegates who have been with us in these 2 days. We are hoping to have an even better learning experience tomorrow, as well as the online delegates, both national and some international as well. So together we have learned. We would like to acknowledge and felicitate our support team in the OT, without whom these last 2 days wouldn't have been possible. Our nursing staff, all our attendants. So I'd like to, on behalf of our entire team, express a lot of gratitude to them.
They have done a fantastic job. At least Salini and team can come to the stage so that we can ask our guests to felicitate them, because the team they have worked for last 3-4 days. Sir, please come. Bhandari sir and Parag.
Next, I'd like to thank our audiovisual team for bearing with us. and especially the delegates who also had to bear with us. So we would like to apologize for any minor or major glitches. But I'd like to call upon our storage people, please come over, and thank you so much for all your support in the last 2 days.
I just want to say, we have integrated OTs, but we are not able to transmit the cases from there to our auditorium or EA. This is the first time we have done from integrated OT. So we have not used the outside people because I am in OT committee, so we have a lot of meetings why this system will not be used. We are giving money to them, but we are not able to utilize. Also, director also told that you look after into it. So we take a risk and tried it, but I think it has happened good. Of course, I think there are some glitches in between. We'll definitely try better in the next year. And they have also some experiences, but anyway, you people have done a great job. Thank you, people have come. Better part is because we are not able to, we are giving nearly 2 to 2.5 lakhs. So that we are able to, at least I think we can save it this time. Let's see. Anyway, thank you, Stars Peoples. Little bit of problem.
Prasanna is not there. Okay, thank you everybody. I hope to see you tomorrow.
सुनाई देगा माइक नहीं चाहिए 2 kilometers just from the venue. So if anybody doesn't have vehicle, we have vehicle arrangement also. So it will be 7:30. 7 to 7:30 it will start. Presidency Hotel it is there. So and I would also request we have a burn center. It's a like it's done from the CSR funds. If anybody wants to visit, can visit it.